Rightio. I declare open the hearing of the Senate Rural and Regional Affairs and Transport References Committee inquiry into regional Medicare access and funding. I'm the committee chair, Senator Ross Cadell. I'm joined by Deputy Chair Senator Glenn Sterle and Senator Richard Colbeck. Senator Jordan Sterle John shall be also joining us remotely shortly. So there. Welcome all. These are public proceedings being recorded and live streamed via the Parliament's website, and a Hansard transcript is being made. Some senators and witnesses will participate via teleconference today. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and as such, action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have the right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground on which it is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I also remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. Finally, I remind all committee members and witnesses who are appearing via teleconference that for the best call quality, it is best to practice using a landline or headphones and to avoid using a speakerphone. That being said, I now welcome via teleconference Ms Marianne Sinclair from the Digital Health for the Bush Network and Ms Karita Hodge from Rural Health West. Are you both there?
Yes.
Thank you. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to the Senate committees has been provided to you. Is that correct?
Correct.
Yep. And for the Hansard record, in the order of Ms Sinclair first, will you please state your full names and the capacity in which you appear today?
Marianne St Clair, Digital Health for the Bush Network.
And Karita Hodge, General Manager with Rural Health West.
Okay. I now invite each of you to make a short opening statement, and at the conclusion of any remarks, I'll invite members of the committee to ask questions. Ms Sinclair.
Thank you. We all know that we have a clinician shortage, so we need everyone working at their higher end of scope of practice. 5 years ago, we established the Telehealth for the Bush program. We had 46 patients go through that pathway. So they would see a nurse practitioner by telehealth, and they would have treatment or be sent for diagnostics or referrals to specialists as needed. And one cattle producer wasn't getting her knee fixed. She fell off a horse. She was 7 hours out of Alice Springs. She ended up getting her having treatment through this program and ended up having her knee operated in the Alice Springs Hospital as a public patient. So that nurse practitioner pathway has really increased access for rural, regional and remote people, and it's been very successful. About that time, we started working with the Gower community. They're a population of about 150 people on an island off the north coast of the Territory. They started their own school in 1985, and they wanted access to a much better health service than what they were getting under the current system. So we worked with them to develop the role of telehealth technicians. So this role is a technical, administrative and communication role, not clinical. And the telehealth technicians provided patient end support, which is really needed for effective telehealth in that context. We've demonstrated that the telehealth technicians have saved at least $400,000 in reduced medical evacuations and associated hospitalisations over the 2 years trial. So the Gower community were very pleased with the results of that project, and they wanted to establish their Gower Community Wellness Clinic manned by telehealth technicians. But on the 1st of November, that dream ended. So what we'd like to see is no face-to-face rule for nurse practitioners, and we'd really like to see an exemption for anyone living in regional and remote areas. You could tie an exemption to that. You could tie a requirement to upload data to My Health Record with that exemption. The NT has an $80 million Medicare shortfall per annum, so you could pile it in the NT and it effectively wouldn't cost anything. The results would be increased access to a wider range of health services, increase the data upload to My Health Record, reducing duplicate diagnostic testing, increase patient safety and continuity of care, provide a level of scrutiny for Medicare expenditure, and if you add SNOMED coding to that, it could really tighten up that monitoring of expenditure and reduce that $8 billion leakage from Medicare.
I'm sorry, I just lost you. Sorry, you just broke up a bit in that bit. You could increase what? Sorry.
You could increase access to a wider range of health services.
Yep, thank you.
Increase data upload to My Health Record and reduce duplication of diagnostic testing. Increase patient safety and continuity of care. Increase scrutiny of Medicare expenditure. And if you add the SNOMED coding to that, it could really tighten up monitoring of that expenditure and reduce that $8 billion leakage for Medicare. It would reduce pressure on emergency departments and emergency services and increase health savings. So it's a win-win-win for everyone. Another thing we would like to see is a consistency in referral processes. And if you get a brand new model of Land Cruiser, you don't test drive it in Sydney. You test drive it in the bush. So if you're going to make changes to Medicare, could you please trial them out in the bush before you implement them? Thank you.
Thank you. Ms. Hodge?
Thank you, Chair, and thanks to the committee for the opportunity to appear today. So just by way of introduction, Rural Health West is a rural workforce agency supporting the attraction, recruitment and retention of health professionals across country WA. We're funded mostly from the Commonwealth Government, the Department of Health, Disability and Ageing, and also we receive funding from the state government through WA Country Health Service. As part of our work, we hold a lot of information around the health workforce that we generate through our surveys and also our day-to-day dealings with health professionals and practice. And some of that I'd like to share today. As you would have seen in our submission and the other submissions for the people who are appearing today, Medicare is designed around patient volume and economies of scale, and those conditions just often don't appear or exist in rural communities. In smaller towns, patient numbers are lower, consultations are often longer and more complex, and through a lot of communities, particularly in the inland regions, communities are served by a solo GP who's responsible for covering the full cost of running a practice. While care is being delivered, the business model that supports that care is often not financially sustainable for the providers. The focus of our submission was really around the work we've been doing with WA Local Government Association and more recently with other sector partners to look at how that is actually playing out on the ground. As referenced in our submission, what we're seeing is more and more local governments stepping in to support GP services for their communities. Back in 2021-22, around 48 local governments contributed around $7.8 million towards GP services, and that had grown in 24-25 to $9.5 million. And 90% of that funding is coming from local governments with quite small populations of under 5,000 people in those inland regions like the Wheatbelt region of WA. That support is delivered in a wide range of ways. Sometimes it's housing and premises, but a significant chunk of that is also in direct financial incentives and income guarantees. And the local governments are doing this because they understand how critical a GP is to the livability of their community. And while this is really noble, the local government intervention distorts the market signals and masks the underlying unsuitability of Medicare in these communities. So GP services continue to operate, but only because they're being subsidised outside of the Medicare system. I just want to touch on, and this hasn't been included in our submission, in relation to the Medicare changes that occurred in November 2025, we've conducted a desktop review of billing practices across rural WA. As of today, mixed billing continues to be the predominant form of billing behaviour, with around 50% of practices using this billing model across rural WA. Around 1/3 of practices are now bulk billing all patients, and the remainder are private billing all patients. Of the practices who are currently bulk billing all patients, half of those seem to have moved to this model since those changes in November last year. And the most significant movements towards bulk billing in response to those changes have occurred in MM5 locations with 13 MM5 practices, which is about a quarter of all MM5 practices in WA, changing billing behaviour since November last year. What I'd like the committee to note, though, is that the strongest moves to bulk billing since November last year have been amongst practices that receive local government support. And that's despite the fact that a lot of those Shire-supported practices were already bulk billing. And I think there's probably two drivers behind this trend. Firstly, there's often an expectation that Shire-supported practices will bulk bill the majority of all patients because of that local government support. And the November changes are quite attractive to practices who bulk bill the majority of patients already. I think the second driver around that is that local government is underwriting the financial risk to some extent for those practices. So practices who know their income is stable, moving to universal bulk billing becomes a safer decision, even if Medicare revenue alone wouldn't sustain the practice under normal circumstances. So the increase that we're seeing in bulk billing, it's really promising, but it's not simply a policy outcome. It's a product of multiple funding streams being layered together. And in some communities, universal bulk billing is still only viable because it's being supplemented by local government funding. I do want to comment, though, that this local government support, while it's really supporting those communities to retain access, it comes at a cost of other reductions in other areas. And the work that we've been doing with Volga and other partners in the sector is looking at how we can exit local governments from that space so they can focus on the activities that they're funded to deliver without making those GP services in those communities increasingly fragile. Thank you.
Thank you. Now open for questions. Any volunteers? I might ask a couple to start off, if that's okay. Ms Sinclair, you describe telehealth as critical infrastructure, not a convenience. For people in regional or rural communities, is telehealth often the difference between getting care and not getting care?
Definitely. That cattle producer I told you about, she wasn't getting her leg treated because it was too much cost-wise for her to drive 7 hours multiple times each way to Alice Springs, stay the night, etc. She had a cattle station to run. There are other people. There was one patient who actually lived in Brisbane, but they were isolated because of other reasons and just couldn't get the help they needed. So going through that nurse practitioner telehealth pathway actually got her the help they needed. And in our case, with the Gower community, they're essentially getting maybe a visit once a week by a nurse, but they're getting no physiotherapy, no mental health support. A lot of their illnesses are not treated proactively early. They have a high, one of the highest rates of rheumatic heart disease. They get treated when they get really, really ill and they get medevaced off the island and end up in hospital. So we're actually filling a gap where there has been a lack of services using that telehealth and nurse practitioner pathway.
Right. You go on in your submission, you list some of the ways you would like to see changes to Medicare and how that's represented for geographic locations. Do you want to outline them now as part of the hearing?
Well, we think that all regional and remote and very remote areas should have an exemption for telehealth for nurse practitioners and possibly for GPs, but definitely for nurse practitioners. I think there's only 3,000 of them, so that's not going to be a huge impost to the Medicare expenditure. And there may be a case for some other people who are isolated for other reasons. For example, in a wheelchair or having mental health issues and they can't get out. There's a variety of people who are isolated, not just geographically, but they need access to alternative modes of accessing health services.
Okay, thank you for that. Might rotate to you, Ms. Hodge, for a second. We talk about the access and the attraction of local government putting some subsidies for to attract GPs, to keep those services in the area. Anecdotally, we're hearing that availability of suitable housing is also a problem for these people, and that's not just keeping the practice viable, but the environment to get them. Are you hearing that too? Is that something that's affecting these remote areas, keeping them?
Look, yeah, housing suitability, affordability is a really significant issue in a lot of regions across Australia, WA. a couple of years ago, we were hearing probably a lot more, and not just around GPs, but also, all health professionals. A lot of practices knowing about the shortage of accommodation, and shires do provide housing just as part of the package. And, what we're also hearing is because clinicians are aware of housing limitations, they're also requesting that, before they accept a role, that they, is there housing provided? Is there, accommodation sorted? I think we're hearing a little bit less around that, and we do actually capture a log whenever we're hearing that as part of our recruitment practices. We're hearing a little bit less the really tight squeeze on things seems to have lifted slightly, but that just could be because practices are now lining up housing and accommodation before they actually make offers to people. I don't know if it's because the housing market has actually improved any.
Okay. When you talk about the number of local government areas supporting the 90% of GP support coming from local government being carried by councils under 5,000, would you say that's where the definite risk is the smallest taxpayer and the smallest ratepayer base, so it is a larger proportion of what their money being offset from other services? Is that a problem?
Yeah, definitely. So, we did some rough numbers before, and, some of these small local governments, it was about, $1,000 per head of population that was going towards retaining a GP service for their community. And, some of these it's happening in communities that, may not have diverse streams of income available to them. They might have, quite ageing populations who are obviously on fixed income. And so, as I mentioned, that comes at a real, a cost to the other services. Like the work that we did a couple of years back where we spoke to some of the shire presidents and said, GPs were absolutely vital. If they lost their GP, they ran the risk of losing the local pharmacy. People might, particularly in these farming communities, people might travel to an alternate community to see their GP, and then they'd do their shopping in that community. They'd, use the baker or the butcher or the pharmacy in that community. So the community who lost the GP ran the risk of losing other services. But as a result, they're sacrificing, road upgrades, they're sacrificing potentially library services, community pool services to retain that GP. So there's a real trade-off for those communities.
Okay, thank you. Senator Steele-John, do you have some questions? I think Senator Steele-John still there? Or dropped out for a second? Right. Might pick up another one. In some of the submissions we've seen, it's talking, and it's not some of the mainstream that's out there, but it was interesting when I was reading through. It's talking about creating special Medicare numbers, or I'm calling them super Medicare provider numbers for regional rural, that allows an increased amount of funding for GPs and allied health professionals. Would that be something that you think addresses the need in some way to get, and I'll go to Ms Sinclair for more nurse practitioners, more people like that out in the bush, and also do you massage after that?
I think the problem is a little bit more complicated than that. There is no GP in Katherine, and Katherine has a population of about 12,000 and services probably another 5,000 people in the Katherine region. Yep. I don't think having super Medicare provider numbers on its own is going to help, but perhaps using our Medicare more effectively. Yep. And providing more flexible billing processes with GPs, nurse practitioners, allied health and pharmacists, and letting people work at the full scope of practice. I think that's the way to go. I'm not sure if I answered your question.
No, you've got it. It's an interesting one. It was just an interesting one for me, where they would allow LGA areas to allocate a higher rate of pay under Medicare things for practitioners in the area. But that's a good one. Ms Hodge?
I am not familiar with the concept at all, so it's not one we've discussed. Yeah,
I get that. Yeah.
yeah, it's interesting. I think we've certainly looked at this issue from a couple of angles, like that, from the funding angle, from the service model angle, from the workforce angle, and I guess we think there's probably a combination of things that need to happen, but from the funding model, obviously the models that, we've discussed are around, block funding or sustainability funding. I don't know if that's similar to like a super provider number. And as, Ms Sinclair also mentioned, nurse practitioner funding and rebates also needs to be looked at, because that they don't seem to be sustainable funding models around nurse practitioners at this stage either.
Okay.
Thanks.
I'll pass to Senator Colbeck.
Thank you. Thank you both for your submissions and for appearing today. I just want to go back to the comment, Ms Sinclair, that you made with respect to full scope of practice. You talked about role for nurse practitioners, providing references off to specialists. You also talked about the telehealth technicians. There is some work going on in relation to scope of practice, particularly for nurses and nurse practitioners at the moment. What capacity do you think that we're actually getting out of the qualifications that are that our nurses and nurse practitioners actually have, particularly in regional Australia?
Look, I think nurse practitioners tend to have many years' experience before they do their qualification, so that experience is probably more important than the actual qualification. But can we also include pharmacists there?
Yes.
Because they have an ability to plug some of that gap as well. In the Territory, we have very limited GPs. Catherine has no GP and probably over the last 4 or 5 years hasn't had a GP reliably in Catherine. If pharmacists could provide some, within their scope of practice, provide some of that plugging of that gap, that would be very helpful. Same with nurse practitioners and our rural, if I'm sick, I want to see one of those rural nurses. They are so skilled. And our nurse practitioner is very, very skilled. So I think it's more about experience and qualifications, but certainly it would be useful if we provided some incentives for that additional training pathway for nurses to progress to nurse practitioner status.
And then fully utilise the skill sets. And I think I agree with you completely with respect to pharmacy. Have you seen much reform occurring in relation to pharmacy over recent times? There has been a number of announcements made. I've seen some in my home state of Tassie where we have some of those smaller communities too, not quite as remote necessarily, but certainly isolated by water, for example, Flinders and King Island.
We were supposed to have a trial here in the Northern Territory allowing the pharmacists to do that extra work, and they've done the training for that extra work. Our local pharmacists had done the training to do that extra work. And I've got a friend who's a pharmacist, and she's done an incredible amount of training. She's very, very skilled. She can do a lot more than just a straight pharmacy job. But that trial was stopped for some reason. I think we need to see more of those trials and evaluations to fill some of that gap. I've had one of our elders spent 30 hours waiting to see someone in ED. She was sent from the local urgent care clinic to ED because they didn't feel that they could cope with that situation. And she spent 30 hours just to get a script for antibiotics. So we really need to start doing things differently. Doing things the same way is not going to reduce the pressure on our health services. We have to be a bit more creative about how we do that, and using pharmacists and nurse practitioners at the higher end of their scope of practice is one way to deal with that, and utilising telehealth, of course.
Well, I suppose it's also getting the most out of the capacity that the system has with the people that we have, given that finding doctors, for example, is really a national stress point for the system.
Yes, it is. But we're also short of everything else. So we're short on physiotherapists, speech pathologists, dentists, dental therapists. We're short on everything. So I'm not quite sure how we're going to tackle that Australia-wide, but we need to try and do things a little differently. Sorry, Brenda.
Sorry, I was going to say there are pharmacy prescribing trials underway in WA as well, though they're still, I think the training is still taking place. I know that they've been quite eagerly embraced by pharmacists, particularly those out rural, but yeah, I don't know that there's been any evaluation completed yet.
Yeah, okay, thank you. I mean, that's the experience that I have talking to pharmacists myself, but also in my home state, there's been quite a bit of work done there, and as I've indicated, in my view, it's about getting better capacity out of the system and the people that we have at this point in time.
Can I piggyback something on there, Richard?
Yeah, I just don't want to lose something out of my mind at the time. Ms. Sinclair, you talked about recognising the experience of some of the nurse practitioners and nurses. Do you think there should be a way that we do that which provides that additional capacity to the way that they practice?
Look, under the vet system, you have recognition of current competencies. Yes. In the higher education system, it's very, very difficult to recognise current skills. I used to do it for a while at the Charles Darwin University in one of the schools there. It's hard. But if we could support recognising current skills in some way for some of those practitioners, that would go away, I think, to helping them achieve that qualification and that capacity to fill some of that gap which is not being met at all at the moment.
Yeah. Yeah. So in a formal sense, who would that fall to with respect to recognising that capacity? Would it fall to the colleges, for example, or how would we design something that could provide that capacity? Do you have any thoughts on that?
Look, I think the GP colleges, Sam, sorry about that. GP colleges are very focused on GPs, and I think you need a higher education provider who has very highly experienced assessors to do that, because they're independent of GPs and nurse practitioners and allied health. I think if you trusted the colleges with it, I suspect you wouldn't get the outcomes that you really want, because they have their own agendas. So I think a higher education provider that is well respected within the industry would be the way to go.
I was thinking more of the professional nursing organisations rather than the GPs, because I suspect you're on the ball or on the mark in relation to what the GPs might want to support or not.
The Australian College of Nurse Practitioners possibly could guide that, but whether they have the resources to do that, that still may have to fall to a higher education provider. Possibly if a project was funded with a higher education provider and the Australian College of Nurse Practitioners, that might be a way to trial that.
Okay, thank you.
Can I just go on your point? Because I am new in the health area, so I'm learning at a rate of speed and trying to catch up on this inquiry. My point was exactly where Senator Colbeck went before. How does the AMA and the RACGP, are they on record as being not overly supportive of enhanced scope for nurse practitioners and allied health professionals?
Oh, definitely. very much so. I've had some of our forums that's come up from our Digital Health for the Bush forums, and I actually know someone that worked in Akron, and they were the actual individual members, GPs, were supportive of nurse practitioners working at the higher scope of practice, but the organisation was not. They were deliberately adding barriers to nurse practitioners working at that higher scope of practice.
Ms Hodge, have you got any experience with this at all?
So RACGP and AMA, WA Rural Doctors Group, are both part of the collaborative that's been looking at this work in these, market failure communities. I mean, they're supportive of the nurse practitioner model. They're really supportive in our experience, or my experience, of the multidisciplinary care. There's obviously a bit of vested interest, if we're talking about moving, away from GP centric care, but they do, recognise that we might need to look at alternate models of care that, embrace nurse practitioners working at top of scope of practice. I guess their view is that still needs to have a GP relationship in there somewhere, is my understanding, but I wouldn't like to speak to them for them, but that's in the discussions that we've been having.
That was getting that relationship good, because it's difficult to suggest answers or fixes that aren't supported will run into other barriers. It's just good context for me, so thank you for that.
Thank you. Thanks. I just want to go back to the questions that Senator Cadell was asking with respect to local government, and it's a pretty common phenomenon in regional areas in particular, where the local shire or council is supporting GP practices. I just want to confirm the number of councils in WA, Ms Hodge, that you talked about were putting in that 7.8, which has now grown to 9.5 mil.
So I think it currently sits at around 52, 53 local governments. Those are the ones who responded to the latest survey. The latest survey was done by Walga, not Rural Health West. But we also knew that some local governments were providing support that didn't respond to the survey. So the number's slightly fuzzy, but it's definitely 50, and it is really concentrated in that wheat belt, sort of upper Great Southern, touching into the goldfields, that inland communities where there's lots of these little communities of a few thousand people, 100 or so kilometres away from one another.
Yeah, okay. Do you know how good the data is in relation to that? I mean, it's the first time I've heard any compilation of it. I know of a lot of councils that are doing it, but do you know if there's any compiled data in relation to that?
So we did a quite comprehensive survey in 2023 to arrive at that 7.8 million figure, and that was quite comprehensive in asking them what type of support, and breaking that down across whether that's housing and premises, etc. There's likely some variability in there in terms of how they attribute costs. So let's say, they're providing housing, are they all using the same accounting method to determine how much that is? Like, is it, net rental, or is that, I know that one local government included in there, they've done some renovations, so that's the figure that they used as opposed to being depreciated. So, it was self-reported. We did go through and verify some of that in annual reports and whatnot. So I think we've got reasonable confidence in that figure. And as I say, last year, Walga repeated that survey and got the increased figure. So, we're reasonably confident that there's, a significant spend there, but there might be a little bit of variability given the accounting from some local governments.
Yeah. Have you seen any? You're talking Western Australian data there, I'm assuming.
Yes. Yep.
Have you seen it in any other of the state jurisdictions?
I think it is an issue that it happens nationally, but obviously our remit is WA, so we haven't gone into those other states to see how widespread that issue. We haven't. I'm not aware of anyone else who's actually collated it in the way that we have with Wulga through those surveys.
Okay, we might have to check with Alga or somebody. That will be an interesting data set to pull together. He's on.
Might try again. We think we've fixed technical issues. Senator Steele, John, are you there, and do you have questions?
Yes, I do, Chair. Can you hear me clearly now?
Yep, go for it.
Superb. All right. Thank you so much for your evidence so far today. Can I ask of Digital Health and Rural Health West, first of all, what issues do you see with the way that Medicare facilitates health provision in rural and regional West Australia beyond those that you've mentioned to us to this point? Because I've been taking some notes on what you've shared to this point with us, but I want to know if there's any additional issues you see.
I think it should be equal pay for equal work. So nurse practitioners aren't paid the same as GPs, and there's quite a few blockages. And the Medicare system, I mean, there's $8 billion and possibly more leakage from Medicare. We've probably got enough money, but we've got to actually improve how we use it better. So having some of that SNOMED coding associated with the billing would be a way to start stopping some of that leakage. The Medicare system is just not working for us out in the regional and remote areas. We're missing out on a lot of the Medicare funded services because we're regional and remote.
All right. And in terms of the issue of directly funding, local governments directly funding the salaries of general practitioners, can you tell me, I think I heard correctly, but was it at least 50 local governments that you've been able to identify in WA that fund a GP position within their boundaries?
So there's around that number who provides some type of financial or, in-kind support. I haven't got the figures in front of me in terms of how many local governments provide that income guarantee or a specific financial payment. But I do know that the value of that income guarantee or financial incentive is about 3 million of that 9 million. But yeah, sorry, I can't at the moment lay my hands on how many of those local governments are doing that.
That's totally fine. Would you be able to get it for us on notice in terms of that figure? Because I think it would really help to illustrate it if we could actually identify how many are in part or in full providing that kind of financial support.
Yeah. I do know my colleagues from Wulga are presenting later on. I can give them a heads up, or I don't know if that's in the bounds of the proceeding.
That could be useful. Yes, that'd be great.
Sure.
And is there anything that either of your organisations see basically that is being done well in this context that the rest of the country could learn from, in your view?
I think Western Australia is very innovative in how they have been using telehealth. They have got teams of nurses or even a single nurse at a single nurse station tapping into support services such as My Emergency Doctor and really doing things very innovatively. And one of the things that, with telehealth, what you could do is allow clinicians in built-up areas or metropolitan areas to provide some services for regional and remote areas. So some of that gap could be filled by telehealth.
Yeah, okay, fantastic. And just finally, in your opinion, Could including dental items in the MBS improve access to dental care in rural and regional areas, in your opinions? And both of your organisations' views on this would be appreciated.
Oh, definitely. The children and the adults out at Gower their teeth are terrible. They're just not getting any dental care. And of course, having many of them have rheumatic heart disease. Bad teeth is bad health. So if we could get access to more dental health services, especially for the adults, the children can get some help through the child dental program, but adults are completely excluded. They just aren't getting any dental services at all. So that would certainly be, a very useful thing to do.
Okay, fantastic. Is that your view as well?
Yeah, look, absolutely. It is one of, I guess, the thing that we've identified, and Rural Health West does a bit in the dental space in terms of providing opportunities for dental students to go out and experience rural practice, and that, gives them an immersion opportunity, but also it provides dental care in some of these communities where they don't have a dentist, and that's pretty significant. And yeah, Medicare for dental would have enormous impacts. Also, the communities that have the least access to dental care in some of the northwest of WA, where you've also got high incidence of renal disease, and there's flow-on impacts if someone can't get on the transplant list, if they have poor dental, need dental care, but there's no dental, services available. So, it's got a real compounding effect not having dental on the Medicare system.
All right, fantastic. Thank you so much. That'll do me, Chair.
Thank you, Senator Steele-John. Back to Senator Colbeck.
Look, just a couple of quick ones. The access, the change in the regulations on the 1st of November have obviously had a pretty significant impact into regional areas. Can either of you put any sort of measure on that and what you're seeing as the impact? Is it sort of telehealth or not much service at all, or how would you describe the impact of the changes?
I could probably produce some of the data from some of our case studies, etc., to give you a little bit of a picture. But essentially, our Gower community cannot access a whole range of services now. But a lot of regional and remote areas, the cattle producers, the fishermen, they have to wait until they get into Darwin or Alice Springs to get access to any of those services. So I could probably dig out some stuff from some of our case studies to provide to you.
That would be really useful, thank you.
And so from Rural Health West, we haven't tracked anything in regards to telehealth, but I do have some, as I mentioned, the desktop data about how many practices have shifted to bulk billing since those November changes. But the PHNs, I understand, might also have that data, so I'm happy to send it through, but there might be different data available from the PHNs. Okay.
And I just want to go back to the telehealth technicians. Ms. Sinclair, you indicated you lost that capacity on the 1st of November. How do you quantify the impact there?
Well, we have an Aboriginal nurse practitioner and a number of nurse practitioners that were happy to provide services to the Gower community for the bulk billing fee through telehealth. It costs about $4,000 to fly out there for the day, so that's just not feasible to do. So I had a physiotherapist that was prepared to provide physiotherapy sessions for the bulk billing rate as well, if there was a care plan done. So basically we've lost all of that capacity that we had planned to implement in our Gower Community Wellness Clinic due to those changes on the 1st of November.
Okay, thank you.
Okay, thank you. Thank you both for evidence today. If we've taken any questions on notice, and I notice, depending upon the answer from Walga, there may be one to that. Can we please provide any responses to the Secretariat by Friday, the 22nd of May? So thank you very much for your evidence, and we'll move on. Thanks.
Thank you.
Thank you.
Okay. I now welcome via teleconference Ms Muriel Cummings and Ms Sally Davison from the Occupational Therapy Society for Hidden and Invisible Disabilities. I remind you that for best quality of call, it is best to use a landline or headphones, and please avoid using a speakerphone. It doesn't come through real well. Understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. And for the Hansard record, will you please state your full name and the capacity in which you appear today?
So this is Muriel Cummins from the Occupational Therapy Society for Invisible Disabilities. I'm one of the co-leaders of OTSI, and I will be appearing today. Sally is an apology, so just myself.
Are you on a speakerphone at the moment? It came through a bit muffled.
I'm on a headset.
Headset, are you? Okay.
I am. Is that any better? I do have a plan B if we do have some problems.
No, that's coming through okay now. We're good. Yep. Okay, would you like to give an opening statement?
Absolutely. Thank you. Thank you, Chair. The Occupational Therapy Society for Invisible Disabilities is a national organisation representing occupational therapists working alongside people with hidden and invisible disabilities across Australia. Occupational therapists practice across a range of clinical settings covering metro, regional, rural and remote locations. OTs deliver assessment and intervention-focused Medicare services spanning chronic disease, mental health, neurodevelopmental conditions and eating disorders across the lifespan, including for First Nations communities. Our central message today is that occupational therapy is an underutilised profession serving rural and remote communities under Medicare due to a combination of long-standing issues and recent Medicare reforms. Occupational therapy can play a pivotal role in primary care and preventative systems in rural and remote communities with the right workforce incentives and policy settings in place to support our practice. Community-based allied health practices are central to rural health systems. They are locally embedded, place-based and maintain long-term therapeutic relationships and can provide continuity that cannot be replicated by other models. A high proportion of skilled and experienced occupational therapists work within small and medium-sized allied health practices in rural and remote communities and townships. Yet Medicare funding structures are placing these same services under increasing financial strain, threatening their sustainability. Recent Medicare policy changes in late 2025 have had immediate and tangible consequences. Our members report cancelled telehealth clinics, disrupted continuity of care and increased travel burdens for clients, many of whom are managing disability-related issues such as fatigue, mobility limitations or mental health conditions. Rising fuel costs and administrative requirements for in-person GP attendance to renew referrals have created additional barriers to access. In some cases, individuals have effectively lost access to both GP and allied health due to these constraints. Telehealth remains a critical enabler of access in rural and remote Australia. However, current eligibility restrictions, such as distance thresholds and limitations on group therapy, do not reflect the lived realities of these communities and risk excluding people who would otherwise benefit from care. There are also long-standing inequities within Medicare rebates that directly impact access. Under the Better Access Initiative, different professions delivering comparable mental health services receive different rebate levels. This creates a structural disincentive to access occupational therapy despite our recognised skills. In contrast, chronic disease management items apply a uniform rebate across professions, demonstrating that equitable funding models are both feasible and already operational within Medicare. At the same time, anticipated reforms and reductions within the NDIS are likely to shift unmet need back into the Medicare system. Last week's ministerial announcement stated that 160,000 people will be removed from the NDIS in coming years. With little services in place to support this group of people living with significant disability, this will increase systemic pressure on both primary care systems and existing emergency and crisis care systems. Medicare must consider expanding the scope of existing Medicare services and add new items to be part of the solution addressing unmet community needs. Our position is that Medicare reform must include a strong focus on upstream preventative care. Investment in allied health, particularly occupational therapy, supports people earlier, reduces risk, and prevents escalation to more intensive and costly interventions. Without this, the system will continue to absorb demand at the crisis end rather than addressing need where it first emerges. We propose a targeted approach, including equitable rebates across professions delivering comparable services, strengthened and flexible telehealth access, intentional incentives and investment to sustain community-based allied health practices. In addition, to address the emerging need that will arise from likely tightening NDIS eligibility and the removal of thousands of disabled people from the scheme, we propose the introduction of a new Medicare item, focused functional strategies, that would complement and provide an escalation point for universal programs such as Thriving Kids and foundational supports. This item would enable access to evidence-based interventions delivered by occupational therapists to build functional capacity across key domains, including executive functioning and cognitive strategies, routine and life skill development, accommodations to support social and community participation, vocational participation, sensory-based strategies, and activity grading and energy conservation. These interventions can be delivered directly to individuals or as part of multidisciplinary care, providing practical outcome-focused support that prevent escalation of disability needs across the lifespan. We look forward to contributing further to the committee's work and to supporting the development of a Medicare system that is fair, accessible and sustainable for all Australians, regardless of where they live. We are happy to provide additional information on any aspect of our evidence, and thank you again for the opportunity to speak today.
Thank you very much. I might kick off with just a question from your opening statement. You spoke that the 2025 changes have made an immediate impact. We just heard previous evidence then that's talking about an increase in the bulk billing rate in some of the regional and rural practices supported by local government, but you're saying it's had a negative effect on some of your members or in your industry. Is that correct?
I guess the changes that came into effect on the 1st of November did create some barriers for people to access services, unrelated to the rebate issue. I think that's sort of a long-standing issue in terms of rebate levels for occupational therapists, but certainly some of the other changes did lead to some challenges, I guess, in accessing care, and that relates to the availability of GPs and bulk billing GPs in rural and remote areas. So what our members tell us is that for some people, it's just not practical for them to access a regular GP. So the fact that they do need to go to a My Medicare registered GP, or the assumption that someone may have a regular GP for an extended period of time before needing care, has meant that for some people it delays them accessing a GP, then that GP creating the referrals that are needed to access allied health professionals, and then sort of being able to access that health professional. So it's added a number of steps for some people, and it's created delays in being able to access a GP for a timely referral for others as well.
Okay. You mentioned that if Medicare better supported occupational therapists and other allied health professionals, you see the biggest benefit at early intervention before people get to a crisis state. Can you steer us, or are you aware of any studies where you can look at not only that happening, I accept that that can happen, but where that could create overall savings in the treatment of patients?
Absolutely. I'm very happy to take that question on notice. Also, I think there is strong evidence that allied health can provide a cost-effective preventative approach for many people that can reduce that need for more intensive interventions further down the track. And we do already see some of that happening, for example, through the chronic disease management program under Medicare, where there is access to a range of allied health professionals. I guess there are some limitations with that program in terms of what conditions fall under it, and also another limitation that I think is probably particularly relevant for occupational therapists is that there are very limited group options under chronic disease management, and if they were available for occupational therapists to deliver services and supports, that would certainly expand the scope of that program broadly, and also enhance that preventative focus that OTs can bring in the management of chronic disease.
Okay. It was certainly, a Sun Tzuism of solve the great when it was small, where you're talking about getting hold of these with the more community-based allied health professionals and therapists, that you get on things quicker before they become chronic. And I know Canada uses it in some regionals with their preventative health system, where you pay to maintain the health of the community versus than fix it. That's what I'm looking at, those sorts of things there. Are you aware of the impact of getting in sooner on big issues and big diseases?
Absolutely. And like I said, I'm very happy to take that specific question around specific studies that relate to OT and to provide them to the committee. But certainly we know with mental health conditions, and occupational therapists do provide mental health support under the Better Access scheme under Medicare. We know there's good outcomes from that scheme. We do feel that the reduction of sessions from 20 sessions per year down to 10, which came into effect in 2022, has probably impacted that capacity to influence that trajectory of those conditions to a significant degree. And that is because for people with more significant mental health issues or psychosocial disability, there does need to be more regular intervention and regular sessions for that transfer of learning of those strategies that we provide through Better Access to mental health. So, 10 sessions may not be enough to have that sort of transfer that may then lead to either lifestyle change or skill development that can have that strong impact in terms of that trajectory. So that's one example. I think, also to give another example, under chronic disease management, there's only specific conditions, like I say, that can sort of be targeted under that. One of them is diabetes. There is some group items available that are not accessible to occupational therapists, but certainly the lifestyle change and lifestyle modification type interventions that occupational therapists can deliver could be a good fit under that group item in the management of long-term diabetes under chronic disease management also.
Okay, thank you. Senator Steele-John is online. Senator Steele-John, do you have questions for this witness?
Yes, I do. Thanks, Chair, and thank you so much for your evidence today, Ms. Cummings. Can I kick off with a first question around what you see as the limitations of Medicare when it comes to healthcare for people with hidden and invisible disabilities in rural and regional areas?
Thank you. That's a good question. I think there are a number of limitations with some of the existing Medicare items that could be expanded to include people with hidden and invisible disabilities or provide a greater scope of intervention for those groups. So an example would be the complex neurodevelopmental disorder items. So that is an item that targets people with neurodevelopmental conditions, and we do welcome that item has been expanded to a degree already in the last 12 months or so. But we are concerned that this item only allows for 25 sessions across the lifespan, and we know that complex neurodevelopmental disorders such as autism and such as significant ADHD, and these are lifelong conditions, and 25 sessions across the lifetime is really very, very little. And when you think about the various life transitions that these groups may need extra support with, the various, so for example, an example maybe that transition from primary school to high school, again, when that group reaches early adulthood, some transitions around transitioning to independent living, and so on. So for that item to meaningfully impact and support a person across the lifespan, they would need access to much more than 25 sessions. And then I guess with some other items, better access to mental health, as I mentioned, these sessions being reduced from 20 down to 10 has meant that for people with disabilities, particularly for people with hidden and invisible disabilities such as autism, such as psychosocial disability, such as intellectual disability, 10 sessions in a year is not enough for that transfer of learning and transfer of strategies to make a meaningful change in people's lives. So to be more inclusive of those groups of people with disabilities, we think it would be really important to increase those number of sessions or bring back those 20 sessions, and then also either enhance the scope of that Medicare item to include additional interventions, or, as we mentioned in our opening statement, to develop a new Medicare item that would allow for the development of skills and the development of function-focused strategies and interventions that would better support people with disabilities under Medicare. And we think that's a particularly important consideration when we reflect on the announcements last week that indicated that 160,000 people may be removed from the NDIS, and thinking about what that might mean for those groups who may be living in rural and remote regions, who very much depend on NDIS support to access the community and also to access health appointments. And so what those changes may mean for people with disabilities and their access to health supports and universal supports really raises a lot of questions.
Okay, thank you. And speaking of questions, do you anticipate a change in demand for Medicare services in rural and regional areas as a result of recently announced NDIS eligibility changes?
Absolutely, we would expect that unmet need to move into other systems. So, that the sheer numbers that have been proposed to be removed from the NDIS, we need to really think about where will those needs go. They won't disappear, they will go somewhere, and it's very likely that they will lead to increased demand for Medicare-delivered allied health services. So they'll have an impact on the primary care system, and they'll also flow into the more emergency-focused and crisis systems also. So I think it's really important, and I think the timing of this inquiry is really helpful, given the announcement of last week, for us to think about how that need could be met under Medicare and what may need to expand or be built to make sure that the Medicare system can cope with some of that extra demand that is likely to come.
Okay, thank you. And what do you foresee any specific types of demand, particularly, that will create pressure on the system?
I think it's difficult to predict without knowing who those cohorts and what those cohorts will be. And we do anticipate that they may be people with hidden and invisible disabilities, people with autism, psychosocial disability, cognitive disabilities, sensory disabilities, intellectual disabilities potentially who no longer meet an NDIS threshold. So these are groups that do need very, very targeted strategies available in mainstream systems so that mainstream systems can be accessed by the group and so that these systems can actually be responsive to those needs. So, we think allied health and occupational therapy in particular can really help to build the proposals and help to build maybe some of the policy around how to make Medicare systems accessible, including for rural and remote and First Nations communities who already, as we know, experience some huge access barriers to support, and to see services withdraw from those communities. I think that's going to have a real impact on access. Certainly for allied health, what we know about allied health services in particular in these communities are that what has made those services sustainable is being able to deliver both NDIS and Medicare and potentially other funding stream programs also. So when you remove Medicare from that, you see that flow-on effect that some of these practices will no longer be sustainable and may withdraw from rural and remote communities, which would be a real tragedy because we'll see the reduction of available services at the same time as increased need and demand.
Yeah. Okay, look, thank you so much for that. That's really appreciated. Thank you so much for your evidence today, and I'll pass back to the Chair.
I'll now pass to Senator Richard Colbeck.
Thank you, and thank you for your evidence today. I just want to get some sense of comparison, if I can, in relation to service delivery in regional Australia versus metropolitan areas, given that's the focus of what we're dealing with. I got the sense that some of your evidence covered the provision of service more broadly with an additional layer, if you like, with respect to accessibility at all when it comes to service in regional areas. Can you give me some sense of that?
Thank you. That's a great question. So absolutely, as with most established health services, allied health and occupational therapists are more concentrated, of course, in metropolitan areas. And what we know about the rural practices that serve those rural and remote communities and First Nations communities, we know that they tend to be smaller, but we also know that they tend to be very established and very committed. So they're often female-led practices that are people who have been very strongly embedded in those communities for extended periods of time. They live in those communities. They have likely, for many of them, raised families in those communities. So we have a very small but very established and very skilled and experienced group of practitioners who do serve those rural and remote communities. They tend to have quite a lot of experience. So, these practices are often led by more experienced practitioners, like I say, who have very often developed that local knowledge, but also generalist skills, so capacity to manage a range of different programs and meeting a range of community needs through the practices that they deliver there.
So how are those organisations in those regional areas going to meet the additional demand that you talked about with the changes coming to, or announced changes to the NDIS?
Absolutely. Well, what we anticipate is that these practices will have more capacity to deliver Medicare services if those workforce if there's policies that support this workforce, then they will have more capacity to deliver Medicare services because there will be less demand for NDIS services. which, at the moment is likely to be a significant proportion of their work. So we think there's an opportunity for those practices to really expand their focus on Medicare if they are given that right support and policy support to do that.
So this is where you talk about a new Medicare item focused on those functional interventions, so that the people seeking that support can actually get it.
Well, yes. So I think it's probably a combination of making sure that the existing Medicare items are I guess, well matched to the skills and the availability of occupational therapists. So it's looking at those existing items and then also considering a new item potentially that could have a specific focus on the support for functional skills and functional independence for people with lower level of disability, so potentially no longer eligible for the NDIS.
So what sort of, you talk in your recommendations, there's 4 there. The first couple talk about increasing the rebates for the therapists, and the second one, the rural complexity loadings. What sort of quantum do you think is needed in those two?
Sorry, was that first part of your question was in relation to rebates, or you broke up just a tiny bit?
Yeah.
So absolutely. So what we see for occupational therapists, for example, delivering services under better access to mental health, we see a significant gap between the rebate for occupational therapists and, for example, psychologists who, for very comparable work, there's a much higher rebate for psychology. So because of that gap, I guess there's a disincentive there for occupational therapists to pick up that work, because in other programs, the rebate is comparable across disciplines. So we really think for better access to mental health in particular, if the rebate were increased, because occupational therapists are then less likely to charge a gap fee or a significant gap fee, that this could be effectively a low-cost way to make sure that better access to mental health does remain accessible to particularly this group that may now no longer be eligible for the NDIS. Because what we know about NDIS participants is that 75% of them, so potentially 75% of that 160,000 people that will lose access to the NDIS, are disability support pension recipients. So for that group, very high numbers, they will not be in a position to pay significant gap fees under Medicare. So they will effectively miss out on better access to mental health under Medicare if there's not some policy changes that mean that item is affordable for them.
And so the second recommendation talks about a rural complexity loading. What sort of support do you see there? What sort of rate would that need to be to cover what's required?
Thank you. Yep, that's a really good question. And I guess there's a few ways to look at how can we provide an incentive for occupational therapists to work with more complex individuals with higher needs who are living in rural and remote areas. So that incentive could be around a better rebate. It could also be around increasing the number of better access to mental health sessions back to those 20 sessions for those groups who have those more complex needs and who potentially are the ones that are at risk of either missing out on services and then only accessing services when their needs escalate to crisis point or needing emergency care. So, which is of course much more expensive in the long run to cover by comparison to building in some incentives sooner for access to more intensive care in the community under better access to mental health.
Okay, thanks, Chair.
Thank you. Thank you very much for your evidence today. If you haven't taken any questions on notice, I think you have seen if you can find some extra data for us on some things. Please have the response to the Secretary by Friday, the 22nd of May. Is that okay? Thank you very much.
Thank you so much. Thank you.
Thank you.
Bye.
Right. I now welcome Dr. Peter Gregg, is it? Yep. Representing Ord Valley Aboriginal Health Service in present, and joining us via teleconference, Dr. Caitlin White from the Aboriginal Health Council of Western Australia. I remind you that for a best quality call, please use a landline or headphones. Speakerphone is not working real well for us today, so thank you, Dr. White. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to the Senate has been provided to you. And for the Hansard records, starting with Dr. Gregg in the room, will you please state your full names and the capacity in which you appear today?
Peter Marie Gregg, here on behalf of Ord Valley Aboriginal Health Service. I'm the Senior Medical Officer.
Thank you. Dr. White?
Hi, my name is Caitlin White. I'm the Public Health Medical Officer at the Aboriginal Health Council of Western Australia.
Thank you. Now, in the same order, I invite you to each make a short opening statement if you request.
I'll hand over to Caitlin for the opening statement. Thanks.
Thanks, Peter. I'll be making the opening statement on behalf of Peter and myself. So good afternoon, Senators. I acknowledge the Murrawang, Garrawang people, the traditional custodians of the land where we meet today, and the Whadjuk Noongar people of the land I'm joining from. I'm Dr. Caitlin White, a GP and public health physician representing the Aboriginal Health Council of Western Australia, also known as ACWA. We are the peak body for 24 Aboriginal community-controlled health services across Western Australia. I'm joined by Dr. Peter Gregg, a GP and Senior Medical Officer at the Ord Valley Aboriginal Health Service, OVARS, there in Kununurra. Archers, while providing general practice services, are not typical general practices. They are community-led services built to address deep-seated health inequities. Archers deliver a comprehensive model of care that aims to be timely, accessible, affordable, acceptable, and culturally appropriate for Aboriginal and Torres Strait Islander people. On a day-to-day basis, the Archers model of care typically supports longer consultations, greater involvement of families in care decisions, and stronger team-based care, where all team members' contributions are valued and respected regardless of position. Our model is necessary to manage the impacts of intergenerational trauma and complex multimorbidity which affect our patients. Archers employ multidisciplinary health teams to provide this comprehensive primary care, with a large focus on preventive care and addressing the social determinants of health, in addition to providing typical general practice services. Archers exist to break down many of the barriers to accessing healthcare that Aboriginal and Torres Strait Islander people face, including cost. Therefore, our Archers have always been completely bulk billing services, and the recent changes to bulk billing incentives have been welcomed. While we utilise Medicare through special exemptions to the Health Insurance Act, the fee-for-service model is fundamentally insufficient to deliver holistic care. The Indigenous Australians Health Program, block funding that Archers receive, is essential to providing a multidisciplinary and comprehensive model. This funding is supplemented by MBS funding and other short-term programs and competitive grants. Sustaining funding streams in this way often contributes to administrative burden, financial instability, and workforce insecurity. To be effective, we need optimised block funding adjusted for patient need and the high costs of recruitment and travel in rural regions. I wish to highlight 3 urgent areas for reform. Firstly, My Medicare. The one patient, one provider model fails mobile patients across our sector who move between different Archers. For example, in the East Kimberley where you are, many patients move between linked services like OVARS, where Peter's the SMO, and Yurrayungi Medical Service in Halls Creek, or Kimberley Aboriginal Medical Services clinics in Balgo, Billyluna and Mullen. While these services are formally linked through a regional consortium and use the same clinical record system and often share patient care, a patient can only register with one of these Archers. Following our national peak body, NACCHO's recommendation in their written submission, we urge the committee to consider reforms which will allow patients to register with up to 3 Archers and make nominating a specific GP optional. Secondly, the assignment of benefits digitisation. These reforms are causing significant stress for our Archers. Given our one-stop shop approach, flexible outreach models and unreliable digital connectivity in remote areas, we recommend deferring implementation until systems are fully capable of supporting our workflow, including being able to utilise an enduring assignment of benefit approach. Thirdly, remote barriers. We recommend broadening the MBS scope to allow other team members, such as nurse practitioners, to claim key MBS items, such as Aboriginal and Torres Strait Islander annual health assessments, known as 715s, and chronic condition management plans, particularly in places where a long-term GP workforce is difficult to sustain. Furthermore, the MBS rebate for haemodialysis in MM6-7 regions should be increased. It currently fails to cover the true cost of providing care. And finally, remote archers acting as the sole provider for urgent and emergency care need dedicated funding that reflects the reality of maintaining 24/7 coverage and ambulance services. Ultimately, a fee-for-service system treats disease, but it does not promote health. For our sector, we urge a transition towards stable, needs-based block funding that aligns with the National Agreement on Closing the Gap. Thank you.
Thank you very much. I might see if Senator Steele-John is here and wants to go first on the questioning. Senator Steele-John?
Yep, thanks very much, Chair. Thank you for your evidence so far today. I just wanted to kick off by asking you to just expand a bit more on what you've shared around the way that Medicare rebates do or don't work in your view in this space. Particularly, I'm wanting to know, how does the Medicare rebate process for non-medical practitioners assist the work that your organisations do?
Peter, do you want to start?
Yeah, I'll start. I'll give OVARS as the example. So obviously remote area 7 with a GP shortage in Australia. We've put out an ad for a GP and we've had one apply in 5 months who wasn't suitable. So looking at that, we're trying to diversify, increasing the scope of other practitioners. So an example is nurse practitioners. We have one at our clinic who provides a pretty similar level of service to a GP. So she's doing really complex diabetes care, CKD, geriatrics. She is more than capable of doing a health check for a patient and coming up with a plan, as well as a chronic disease care plan, but she cannot sign off on them. They then need to come and see the GP. So I think for regional and remote areas where we have this huge shortage of doctors and we're relying on other practitioners who have that scope, being able to expand the Medicare access so she could then bill, or your nurse practitioners could bill, that would sort of unburden the GPs from having to do that work that she can already do. So that would be one example. The other examples, we have nurses who can do things like putting in contraceptive implants. At present, they can't bill for that, so it has to be, if you want to bill for it, the GP really needs to do that and spend that time. AHPs can prescribe certain medications for simple conditions. So an example would be an uncomplicated STI. An AHP has the capacity to prescribe but cannot bill for that consult. So if we can increase the scope of our workers and use them at the top of that, the current fee for service doesn't reflect that work that we're doing, but we're in the situation where that is how we're practicing because there's no other choice. So it's around that financial compensation and what works best for a rural, remote place. Caitlin, did you have anything to add?
Yeah, totally agree with everything that Peter has said. I would say the way that often it works in our services is that a GP will have to sign off a 715 health check, so an annual Aboriginal and Torres Strait Islander health check, or a CCMP. And then if the patient returns for services according to that plan, we can bill a 10987 or a 10997 when care is provided by a nurse or Aboriginal health practitioner. I think, that works well, but as Peter said, you need to have those things done in the first place, where if you have a GP shortage, that can be really difficult. So then basically you're missing out on any ongoing funding for providing care that people need. And we know that our services, regardless of whether a person has completed their health check plan and it's been signed off by the GP, we know our services are providing that care regardless without being remunerated, particularly those other multidisciplinary team members who provide a lot of care and spend a lot of time for patients without being able to bill. Another small example is when Aboriginal health practitioners provide an immunisation for a patient, the GP can claim an MBS item 10998, I think it is, on their behalf, but that's not available to nurses. So there's probably a few gaps in the system about the care that we actually provide.
All right, fantastic. And in the view of your organisations, could the administrative process be improved around Medicare to better fit the regional ARCHO experience?
Peter, do you want to go first?
I'll let you go on that one, Caitlin.
Okay. I would say, yeah, definitely. I think, as I'm sure you are all aware, the Medicare system is very complex, and for our sector and our services, it requires constant training, not only of GPs, but of all aspects of the care team to make sure that we're billing according to the services that we're providing. I think in general, our services would underbill because it's quite time consuming to make sure you've got all the right numbers for all the things that you've done. And it's another cognitive and mental load on usually the doctor who takes responsibility for billing to make sure they've claimed all the correct items. And then most of our services will also employ a Medicare officer to process claims and monitor things. And the practice manager and other staff all require ongoing training. And I think every time we have a Medicare change, it takes a lot of effort for our staff to get across it. So as a peak body at ACWA, we try our best to support our member services to understand Medicare changes, the recent bulk billing PIP changes and bulk billing changes, but it does add a lot of admin burden, one of which at the moment is with the bulk billing PIP. With the 50-50 split between GPs and the practice, we really strongly feel that decision wasn't made in consultation with our sector or with our sector in mind, because most of our GPs are salaried, and we're all bulk billing already. So there's been a bit of confusion and conflict at times with that 50-50 split, where if GPs are taking the 50%, it's not shared across the team and back to the service. So most services are spending time negotiating contracts with their GPs to have the 50% redirected, given that they're salaried medical officers within the service. That's one example of the administrative burden that we face.
Caitlin, I might just add to that. So at our service, we've had nearly a total change of clinical staff. I think there's one or two that have remained after a 2-year period. So in that time, I would say on average it takes at least 6 months to get a new staff member up to speed with how to bill Medicare, how to do it properly, make sure they're billing it correctly each time. The amount of time it takes, I sit and do some mentoring with the nurses and AHPs, auditing, and frequently there's item numbers missing. So we know we're missing income. And then we know the high turnover of staff will be in the same position in another 1 to 2 years where you start again. So it's a constant, that burden of just having to constantly be training and make sure that we're billing for what we can be. Definitely there's money there where we'll be missing out on for the fee for service.
Is that a function particular?
Thank you.
Sorry to butt in.
Just to follow up here.
Sorry to butt in, Senator Steele-John. Is that a function particularly peculiar to an ARCHO?
I think it's in an ARCHO, particularly rural and remote. It's just generally there's high turnover anyway. What I see in a city practice, you tend to see people staying a bit longer, and they're predominantly focused around a GP who gets training in Medicare. You don't see that same level of training for AHPs, RNs, which is quite unique to an ARCHO or rural remote.
I was referring a little bit more towards the employment practice.
In terms of the service?
Well, you're all salaried GPs, for example. Is that a...
Sorry, I don't understand the question.
You're saying there's more predominance of salaried GPs in ARCHOs than there are versus other practices, yeah?
Correct. There are some ARCHOs where they get a percentage of the billings and a salary, so it's a mix, but generally it is more salaried.
Okay.
Yeah.
Sorry, Senator Steele-John.
Back to you, Senator.
That's all right. in your opinion, could the inclusion of dental items in the MBS improve access to dental care for First Nations people in rural and regional areas?
Sorry, could
So
you?
it was the inclusion of what?
Dental care items in the MBS.
Oh, yeah. Yes, I think so. Yeah.
So that, could it improve access to dental care for First Nations people
yeah.
in your cohorts?
Yeah, I think 100%. Dental care is one of the biggest needs for our patients in our sector. Many ARCHOs will employ a dentist off their own back and find other funding mechanisms to employ a dentist so their patients can have access to dental care. But if the dentist was able to bill the MBS, I think it would revolutionise the way that we could provide dental care to patients by being able to more sustainably employ a dentist. So right now, I know many services, I'm not sure what OVARs do, I'll throw to Peter in a second, but many services will utilise their other MBS revenue as extra revenue to employ something like a dentist. But yeah, if they could bill themselves, that would be great. Peter?
Yes, dental is one of the biggest neglected parts of the body in all of Australia, I would say. So we rely on an RFDF dentist and then a dentist at the hospital who visits on average once a week. It's nowhere near enough. The state of dental health is pretty dire. We're sending away patients with rotten teeth and they'll wait 1 or 2 years before they're even seen. I know there's other AMSs who, like Caitlin said, they've funded it themselves, but if there was a Medicare access for a dentist, it would be a game changer, especially out rural and remote where we're already struggling to recruit dentists as well. Yep.
Fantastic. Thank you for that. Thanks for that. That'll do me, Chair.
Thank you, Senator Steele. John, given your questions, I should actually go on the record and say I have a potential conflict of interest, so given my wife is a dentist and worked with the RFDS. But there you go. Senator Colbeck, do you have anything here?
Yeah, I'm just curious in relation to the work with respect to nurse practitioners and the training of nurse practitioners. What is let's say the weighting of nurse practitioners within the ARCHOs, which and what is the practice with respect to supporting their training? Because there would be a lot of particular requirements for working within the ARCHO sector.
Yep, so at the moment we've got a nurse practitioner student who's doing her 2 years of training with us. So yes, it requires a degree of supervision and willingness of a GP mentor and a nurse practitioner mentor to oversee that training. It's quite in depth, so I'm helping our student looking at the material they're studying. It's quite involved and very similar to what you would see in medical school. And from what I've seen of nurse practitioners, generally they're coming from backgrounds where they're already quite experienced. So I see a lot of remote area nurses who are already working in that space where they need to do their own assessments, try and do their own diagnoses. It's sort of that next level where they're getting those skills to be able to prescribe, further their diagnostic skills, differentials for diagnoses and coming up with management plans. So it's quite well supported, safe. Obviously it depends on the candidate and their interest area, but the nurse practitioners I've worked with have been in primary care and they're waiting in the clinic while they can't cover everything a GP would do. So an example would be they wouldn't have those skills around seeing children with developmental issues, but when it comes to chronic disease, which is that large burden of healthcare, that's their sort of scope and area where they shine and where they focus on a lot of their training. So it does fill a bit of the gap.
Yeah, it's an interesting. You mentioned the experience that they gain prior to coming in. We had a witness earlier talking about the amount of experience that many of these nurses have, and the way that's recognised professionally. would you see some benefit in a process that did have the capacity to formally recognise the experience that they have developed, which would also support them in providing care, appropriate care, and I think that's probably the thing we need to remember as part of this all the way through, appropriate care as a part of their scope of practice?
Yes, so difficult question to answer. So an example, when I worked on Groot Island, it was mostly with remote area nurses. It was of varying levels of scope, so some had very minimal and others were incredibly experienced. And what I noticed was there was no benchmark or standard where you could qualify and say that I know a RAN has all of these skills. It depended on each individual. So I guess that's where I see at the moment there's a lack of being able to define what that scope is and what a RAN can do, which is where I think the NP takes it to the next level, because you have to pass your assessments, case studies, whereas the RAN side is lacking in that area. Could that be developed? Maybe, but I think it would need quite an intense supportive program.
Would the same apply to nurse practitioners? Because there is a level of experience which gives them a capacity that is not just about their initial qualification, if you like, passing of their initial qualifications. And I'm just taking this based on the evidence that's come to the committee today, that how we might enhance the way the system operates or give it more capacity by recognising that experience and whether or not there's a value in that.
I think for the nurse practitioners, they go through their credentialing process where they define their scope at the end. So they do need to provide evidence that they are practicing within that, and they actually define what it is that they can and can't do. So I guess there is a degree of that already.
Okay.
It depends on state by state as to how lengthy that process is.
You're opening a whole new rabbit burrows there, but it's probably a valid one. So I suppose the obvious question there is that there would be some value in consistency across state jurisdictions, so that would facilitate people being able to move easily with respect to their employment or healthcare service provision.
Yes, yeah. And look, it's similar with GPs. I mean, a GP who's worked across the top end of Australia in First Nations health needs a lot less assistance when they move here and work in Kununurra than a GP moving from inner city Melbourne. So it would be the same with nurse practitioners. You're going to find anyone coming to First Nations health is quite complex chronic disease that can be quite overwhelming in the context of all those social determinants of health, quite confronting. So I think GP, NP, it is quite similar, but yeah.
Okay. You talked about the role of block funding in relation to service provision. Could that provide a more efficient operation of service, and with the right parameters, a better way and a more economical way to deliver service?
Caitlin, do you want to start with this one?
Sure.
And then I'll add on.
Yeah, I can start with this one. I think both our submission and our NACCHO, our National Peak Submission, talk to this point, and particularly point to some work that NACCHO did with equity economics pointing out the burden of disease, which is 2.3 times greater in Aboriginal people than non-Aboriginal people, and the funding that it's actually required to not only address the burden of disease but do preventive care properly. There's a massive shortfall, estimated at $2.6 billion shortfall in Commonwealth health expenditure relative to that need. And I think, from the perspective of our sector, we would like to see the block funding increase but be optimised relative to need. So the needs within all of our art shows, whether that's in the metropolitan, regional or remote areas, are very great. As Peter mentioned just then, when you're working as a GP or an NP in one of these services, the level of complexity you see in your patients is so high, and the time required to provide comprehensive quality care and also to overcome the barriers that people face in accessing their care, getting to the clinic or, is just one simple barrier that we help to facilitate. So we have drivers, we have transport officers, we have people that need to follow up recalls and find people who are unwell. All of that is very expensive to do, and we don't have enough resourcing. So most archers will apply for short-term program funding so that they can offer other services in addition to the clinic services, whether that be social and emotional wellbeing services or counselling services, physiotherapy. Some services will employ multidisciplinary team members and allied health so that patients get that service. But we often need to be scrounging around applying for competitive grants, which have high administrative burden with reporting. And so it's very difficult for our services to sustain that. And what we'd like to see is a funding model that looks at the need based on socioeconomic status of the area, number of patients, complexity of the patients, Indigenous status, and provides a model that can fund the service for what they're providing and their needs in a block funding manner, so that we're not out trying to find other funding sources. So, yeah, I think the work that Equity Economics would point you towards that, but that's the way we'd like to see things going. And, we do spend a lot of time trying to optimise our MBS billing, like we've said so far. And just to add to that, I think, you mentioned the salaries before. It is quite unique to art shows that we provide salaries to our GPs, and that's really because the Medicare model wouldn't be able to fund the work that our GPs do and recruit and attract GPs, because we spend a lot more time with our patients than we would in private practice. In private practice, you're seeing a patient every 10 to 15 minutes, usually every 10 minutes, whereas if you saw 2 patients in an hour in an art show, that's quite a lot of work. And so that's why we provide salaries, but our salaries are currently unable to compete with the salaries offered by WA Country Health Services, so the WA Health System, for doctors to work in hospitals, and also the new urgent care clinics are offering salaries way above what we could offer. So that's also contributing to issues with our workforce recruitment and retention.
Just to the urgent care clinics, do any of your services qualify with respect to that program or receive any support through that program?
Some are qualified to apply, but I'm not aware of any art show in WA who's been successful in applying for an urgent care clinic. We've certainly had art shows apply, but they've gone to mainstream providers rather than art shows, so not at this stage.
Okay. That was a little bit off the point. Dr. Gregg, have you got any commentary to make on that? I mean, I was really listening to the evidence that you gave about the efficiency of the way that a practice could operate, and I appreciate the discussion around the overall shortfall of funding. I get that, yeah. But is there capacity to get a little bit more out of the system? And your evidence did indicate a lot of toing and froing and organising based on the way that the system is structured.
Yes, so I feel like often we do try and work around the Medicare system to optimise funding, whereas if we didn't need to be spending that time, we could be delivering more quality care. An example of this, so at our practice we've got a funded position for a rheumatic heart disease nurse, so super high rates in Kununurra of rheumatic heart disease. Her role, because it's funded, she's quite flexible, dynamic, so she's a mix of in the clinic and then out doing home visits. Got a lot of patients who don't necessarily want to engage for different reasons, high disease burden, having to go to hospitals, clinics, so she's able to go to their house to do their monthly antibiotic injections. She does so much more than just the rheumatic heart. She'll also, when she's at the home, go, hey, I see your washing machine's broken, there's rubbish here. She'll do the environmental health referral. She'll notice their teeth are not in great condition, she'll do their dental referral. So it's such a holistic thing that if that patient walked in and saw me in a 15-minute appointment, there's no way any of that would get done. So I think that block funding in that respect, you get a lot more out of it by focusing your time on what matters rather than trying to chase the dollar. Yeah.
And I just want to go back to the point that you made very early in your opening statement with respect to the mobility of patients and the requirement to register at one location.
Yes.
What would be the ramifications of having multiple locations for registration, and how does that affect delivery? Are these patients well known at each of the practices that they're accessing, or how do their medical records, for example, get managed as a part of that process?
Yeah, so in the Kimberley, so Brahms, Dars, Ovars, Halls Creek, we all use the same computer system, MMEX, so patients can consent for their file to get merged, so we can see everything written in each of the clinics.
You're the same consortium, that's what that refers to?
I think Caitlin was referring more to the ARCHOs across WA, but in the Kimberley, sort of we are known as a clinic, and we use CAMS as sort of the overall umbrella, even though we run independently. So there's a lot of patients between Halls Creek and here where Halls Creek might be their primary clinic, so we would let them do their health check and their GP management plans, but they might come to Kununurra and stay for 4 months because of family business, business. So we're providing 4 months of chronic disease care, not being able to, benefit from some of those incentives. And it's quite common in Broome. There's a lot of patients moving between Beagle Bay, Broome, Derby. So just with interconnected families, it's very common, and it is hard when people are coming to the clinic for months at a time, but you can't then access those incentives. Caitlin, did you have anything you wanted to add?
Yeah, I guess the other example is when people travel from a remote or regional area, say they come from Kununurra and they have to go to Perth for healthcare, for an extended period of time. Could be while they're waiting to give birth or for an operation or a range of things. They'll often attend Derby-Yerrigan Health Service, which is our metro ARCHO here in WA. And again, that service then is providing chronic disease care and providing all of the things that they would be getting back where they're from, but they're unable to access the benefits that are associated with My Medicare. But yeah, I think Peter's example of the Kimberley is a really good one where the care is quite safely shared between different services or clinics through the same computer system, but the patient can only be registered at one service where they might actually spend 6 months of the year in Kununurra and 6 months of the year in Halls Creek and have care from both places. And I think the other part of that My Medicare issue is that for My Medicare, you have to nominate a preferred GP, whereas in our clinics, most care is shared. So you might not see the same GP every time you're accessing a team of GPs who share the care. So that can often be quite difficult and quite confusing. So people can't access the benefits associated with My Medicare because they have to name a particular GP.
Would that care across multiple GPs be regarded in any way as a different level of service?
I don't think so, no.
Okay, that's okay. Thank you.
Yeah, I think you'd find that art shows are a really great example of team-based care. So it's very different to private general practice where your GP sort of sees their own patients. There's very little discussion or sharing of care. Whereas in an art show, it's very common to seek an opinion from another GP, have them see your patient, share the care, make sure that the patient is followed up, have team meetings. There's a lot of people within the service who'll know the patient and provide care. Do you agree, Peter?
Yeah, that just today I saw a patient this morning. So her normal GP she would see was on admin today doing discharge summaries, different things. She was quite unwell, this patient, normally sees Marnie. I'm her backup doctor, so most patients will have 2 or 3 that they'll go between. So I just picked up where Marnie left off, and then we had a chat later to discuss. She's a really complex case about what we're going to do, and the patient's involved in that, and she's very happy for both of us to be putting our heads together. And then when I'm away, she'll see Marnie. When Marnie's away, she'll see me. So that's quite common across all the AMSs that you'll be seeing multiple GPs.
And therefore a function of the way that art shows operate.
Yes. Yeah.
Okay, thank you. Thanks.
And that would also be a benefit of the salaried positions where you're not competing for your 50% of your...
Correct.
Yeah, it's all teamwork.
So it's team-based, yeah.
Yep. Okay.
Yeah.
I want to get onto that money a bit. So, Dr. White, you spoke of underbilling in the opening statement. We've heard other things there. Dr. Gregg, you mentioned about not able to claim for certain things, STD and contraceptives. You both spoke about going to the art show in WA where the transfer for chronic care and not being able to claim something under my benefit. So is the government benefiting from this in getting free care when you do this because you care, rather than is the government, is the health department benefiting from your goodwill and doing services, saving money because you do it anyway?
I think so. That's my opinion. Okay.
Yeah, I agree. I think our aim is preventive care. We want to prevent hospitalisations. We do not want people ending up in hospitals. And I think if you came to one of our services, you'd see the amount of effort every member of the team does to help patients, support them, provide care, provide transport, do all the things so that life's better for the patient and better for the health system. We don't want to see people sick in hospitals. So, totally. I think we're doing a lot of work unfunded or for not enough funding, and the funding doesn't recognise the complexity of what we do in an art show. It is not like seeing a GP in private practice and going in and out in 10 minutes. It's a lot more complex, and the Medicare system doesn't recognise that fully. I think there's parts of it where we do our annual health checks, and we get paid to assess the patient and make a plan for them. So that is an important item, the 715, but it doesn't account for all of the management of what we do financially.
No. I'm asking this question from a position of love because I don't want you to see it as a negative thing. Do you think if you were 100% billing for all the things that get done, even if it's a nurse practitioner doing 715-ish type thing or something like this, or the STDs, if you were 100% billing under the current method, I don't want to go to that method because I accept it's difficult. Do you think you would be more viable and able to do more if you were getting 100% funding for everything that you did?
Do you mean through a fee for service?
Oh, no. I know you don't love the fee for service. I'm not saying let's go to a fee for service is better. I'm saying if the amount of funding was there per se for everything you're not doing, it would be a better system already.
Yes. Yeah, it would be.
Yep. You had that certainty.
Yeah.
The quantum wouldn't change for the value of service you're doing, just the way it's delivered would be changing. So the amount, okay, I understand that. Okay. What's when we go down this plan of going forward, I always, as I said earlier, I'm new in this health space. This is one of the first health inquiries I've ever been, other than the dentistry one that I did with Senator Steele, John. How do we feel that there is a difference between Aboriginality and Indigenousness and health, but also remote? You're copying both of the difficulties at one. Has there ever been a breakdown between Aboriginal services in built-up metro areas versus regional, and the difference between those deliveries and costings?
I don't know that I could answer that. Caitlin, have you got information?
Sorry, could you just rephrase the question?
I think
is there a difference between metro and remote?
Yeah, because I think there's two difficulties we're dealing with in rural. There's the Aboriginality, which is a contest in itself, but then there's regionality, which is, we hear, for non-Indigenous people is a challenge too. Both of these things stacked up on one another. Is there a difference in cost delivery that we've seen that we could actually increase the funding for regionality as a thing on top of Aboriginality as well?
Yeah, well, I think, the Medicare system does do that with, like, the bulk billing incentives. They've got different amounts that you can claim. They're completely different numbers based on region. So there is definitely a rurality component that as you get more remote and the costs increase. That is 100% true. I would say we do know that the complexity and the burden of disease also increases as you become more remote, but I think the metropolitan archos still have a very high burden of disease and complexity, and usually a greater number of patients. So there's that complexity extends no matter where you are, but certainly the cost for delivering care increases a lot as you become more remote. Okay. Is that sort of...
Yeah, I get that. You raised an interesting point about the 50-50 split under the changes that went through it. Has that caused any doctors to leave, the conflict over that and that split?
No, because at our clinic, all very caring and all staying. However, locums, it is a massive point of contention. We have sort of said that we will be writing into locum contracts. If you would like to come, we will be keeping that money, but there's no way to police that. They could go onto their PROTA, change the banking details and take that money.
Don't they have a different provider number when they come here than everywhere else that you can track that way?
I think it would be, you would need somebody to be checking every dollar that's coming in of that, and we don't have time to do that. So we're just kind of relying on their good faith and the fact they've signed a contract, but in reality they could go on and change that specific provider number.
Yeah, that's what I thought, yes. So locums, it is a challenge. Yeah, okay.
Yeah, so we've...
And I think, I don't know specifically if people have left because of this, but... because they probably wouldn't say that's why they're leaving, but I suspect that is happening, or that people are considering other jobs because they feel like they're being shortchanged with the 50-50 split. But yeah, the locum issue is across the sector, that when you say to people, we would want the 100% directed to the service, they say no, they go find a different job.
Okay. So even if they're not leaving, they're not coming.
Correct.
Yeah. Okay.
Yeah.
Thank you.
I think some might be leaving.
Yeah, I hear you.
Not at OVARS.
Anecdotally, we might say, okay.
Anecdotally, yeah.
Okay, well, thank you for your evidence today. I don't think there's any questions on notice, but if they are, can they please respond to the Secretariat by Friday the 22nd of May, and we'll now pause for a short break.
Thank you.
Thank you.
Rightio, we are back on, and I now welcome Mr. Nick Sloan and Ms. Hannah Godslave from the Western Australian Local Government Association, who joins us by teleconference. I again remind you, for the best quality call, we've had some issues today, but it is best to use a landline or headphones, and please avoid using speakerphone. If it comes through a bit garbled, we may pause for a second and try and get that rectified. I understand that the information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. Is that correct?
That's correct.
Thank you. And for the Hansard record, will you each please state your full name and the capacity in which you appear today?
So Nick Sloan, I'm the Chief Executive Officer of the Western Australian Local Government Association.
And Ms. Hannah Godslave, a Community Policy Member at the WA Local Government Association.
Right. I now invite you to make a short opening statement. At the conclusion of any remarks, we will be asking questions.
Thanks very much, and thanks to the Chair and members of the committee for the opportunity to appear here today. And I'd just like to acknowledge that we're joining you from Wadjuk country here down in the southwest of the state today. The Western Australian Local Government Association, or WOLGA, is the peak body representing all 139 local governments across WA, which includes 109 regional and remote LGs. We're an independent, not-for-profit based organisation, and we seek to use our influence and support and expertise to deliver better outcomes for WA local governments and their communities. So WA local government serves some of the most geographically vast and diverse communities in our nation. And while local government plays a vital role in community wellbeing, the provision of primary health care is fundamentally a responsibility of other levels of government in Australia. All Australians, regardless of where they live, deserve equitable access to essential primary health care services. However, for many rural, regional and remote communities, that equity does not exist. Relatively small populations, complex health needs, workforce shortages and higher delivery costs mean that general practice services across much of regional WA are not financially viable under the current Medicare funding model. As a result, local governments are increasingly intervening, not by choice but out of necessity, to ensure their communities can access basic GP services. WA local governments spend over $9.5 million in 24-25 supporting the provision of GP services. Over 90% of this expenditure was borne by local governments with populations of under 5,000 people, mainly in our wheatbelt and goldfield regions. These local governments are providing income guarantees, facilities, accommodation, vehicles, administrative support, and even directly contracting doctors, often committing hundreds of thousands of dollars annually from very limited ratepayer bases. This level of support is unsustainable and goes largely unrecognised. It diverts scarce resources away from core responsibilities such as community infrastructure, town planning and the operation of municipal facilities, arguably where the sector can add most value to enabling healthy communities and reducing pressure on hospitals. While recent federal investments to improve bulk billing are welcomed, they do not address the structural limitations of Medicare in rural and remote settings. Bulk billing incentives alone cannot overcome market failure, workforce isolation, or the fixed costs facing small, independently owned practices. The consequences of inadequate primary care is clear: higher rates of preventable illness, avoidable emergency department presentations, and preventable hospital admissions. Rural and remote Western Australians face poorer health outcomes while having significantly fewer GPs per capita than metropolitan populations. Local governments in rural and remote areas should not need to underwrite the Medicare system. Meeting the primary health needs of rural West Australians requires the federal government to lead and invest in alternative place-based service delivery models designed for rural contexts, supported by sustainable funding. WOLGA is advancing work to identify practical evidence-based solutions to these issues. We're working closely with Rural Health West and other key health sector stakeholders to identify viable alternative service delivery and funding models for rural and remote communities. This work is focused on delivering place-based approaches that can deliver sustainable primary healthcare outcomes and remove the need for ongoing local government financial intervention. To progress this work from concept to implementation, federal leadership and support is critical, particularly in providing seed funding, flexible funding mechanisms and policy settings that enable these models to be tested, refined and scaled. My colleague Hannah Godslave will speak to this work in more detail and outline the opportunity it presents. Chair, without reform to the current Medicare model, local governments will continue to carry a burden they are neither designed nor resource to bear. Addressing this issue is essential not only for rural communities but for the sustainability of Australia's entire health system. Thank you.
Thank you. Ms. Godsave, were you going to expand there or wait for a question? Yep.
I'll wait for the question.
Okay, I'll give it to Senator Colbeck.
Smart move. So we heard from a previous witness that there are about 52, 53 councils that are providing what was, I think, in 2022, 7.8 million from my notes, and by 2024 it had gone to 9.5 million from those 52, 53 councils. Is there a formal process for gathering all of this data within the local government association? This would be, I think, valuable information nationally. So what is the quality of the data on this, or are we still commencing the process or a couple of years into the process of gathering the data?
Look, thanks for the question. I'll have the first go at answering, and Hannah can tidy it up if need be. But look, essentially, we as the association representing local governments, we're not the regulator. So local governments aren't obliged or compelled to provide this data to us. We initiated this data collection a couple of years ago because obviously we were becoming more and more aware anecdotally of the direct and indirect costs that were being borne by local governments in enabling the provision of these primary healthcare services in regional Western Australia. So the data is collected, and this year we worked with Rural Health West to assist us with the data collection. But effectively, it's information that's voluntarily provided by our member local governments to assist us in building the evidence base to be able to have informed discussions like the one we're having today. So it's a response to surveys that we put out to our membership that informs the sort of the data capture and reporting that we're talking about.
So are you aware of any other conversations like the ones that you're having through ALGA or any of the other state local government associations?
So in response to other jurisdictions, so we know anecdotally through our work with other associations and ALGA that this is an issue for our counterpart local governments in other jurisdictions. However, to date, we're the only association that has collected data to underpin the extent of the support being provided. I know that New South Wales have touched upon the cost impost with relation to health support as part of some broader work around financial sustainability, but nothing as unique or bespoke as the work that Wales has done.
I would have thought, though, if a community of under 5,000 is paying something of the order of, I think the evidence was something like $1,000 per ratepayer for ensuring a service which the provision of was the responsibility of another level of government, not them, and I know why they're doing it. I understand that. I see that at home in Tassie. It would be in their interest to provide this information. So,
as in the individual local.
Yeah, I mean, it would be in a council's interests for a community, or for it to be known how much it was pitching in to basically do what another level of government should be done. And I know councils do this a bit, but this is a pretty fundamental service for all Australians, which is one of the reasons we're sitting around the table today. What analysis has been done of the work? Is there an average, say, per resident that the councils are tipping in, or does it vary, depend on the different shire or council area, LGA?
It varies considerably across the different shires. So through our work, we came to the conclusion that, you know, a per capita costing was actually not the most useful diametric to use to understand the data. But what we do, so there is a group of local governments in the southwest of WA that are doing some independent work on this as well. And their data around their cost for supporting primary healthcare services actually makes the comparison between the cost of funding the service as a proportion of their rate space. And I can tell you from that information that some of them are as high as 16% of their total rate space.
16%, 1/6.
Yes.
And look, what I'd add to that is this is an issue. This isn't the first time we've been raising this as an issue in discussions with both state and the Commonwealth. So this has certainly sat within the broader work that we've undertaken in the lead up to state and federal elections, and also successive budget processes at a state and federal level as well. What we've been very keen to do is be able to quantify to the extent possible what the costs are. And look, whilst we have a lot of confidence in the data that we're talking about today, the reality is there's still probably a degree of underreporting in relation to getting responses back from our entire membership. So we would suggest that 9.5 million is the minimum level of investment that's being made across the local government sector at the moment. And as Hannah's indicated, when you're talking about 16% of the rate base for some smaller regional shires, the opportunity cost associated with having to meet the provision of these services is that they're not able to invest those funds into the broader range of municipal services that local governments are responsible for.
Yeah, and look, I mean, so prior to life in this job, I was involved in local government, although at a regional city level, not or a more remote community level, but I see it across my communities as well, which is why, so I'm really interested in the data and the quality of it and how you might quantify it, because one of the things that the committee can look at doing is, okay, what is our recommendation as how we address it, which is why I'm asking you the questions. I mean, so could you apply, for example, a remoteness index to the data in the way that the numbers are calculated? You're talking about, proportion of rate base is one way to look at it, and so if I'm a public servant trying to build a solution, how do I start making the numbers stack up to put an adequate solution to a councillor who's having to attribute 16% of its total rate base to providing a service it's not supposed to be responsible for? I mean, how do I design something that makes that work? Which is why I'm also asking about the national data in other jurisdictions. Yeah, I mean,
absolutely. We could look, our Salaries and Allowances Tribunal here in Western Australia effectively establishes 4 bands or 4 classes of local government in Western Australia, and they're largely based around the size of the local government and the overall quantum of expenditure from that local government. But then also within that, from a regional perspective, they do look at the sort of the remoteness of that local government authority, and that then determines whether or not, for instance, when you're recruiting a CEO, you're eligible to apply an isolation allowance to the salary of that CEO based on the location. So we could certainly line up our data with some of the metrics that are used by the Salaries and Allowances Tribunal here in Western Australia. I think our argument fundamentally, though, is that these costs are costs that shouldn't be borne directly by the local government regardless. This isn't a service that's within the remit or function of local governments to be providing to its communities. So I guess from that perspective, notwithstanding the value in being able to look at the remoteness associated with this, we have a degree of confidence in in what the numbers are telling us in terms of what local governments are having to spend to directly provide these services.
If I could just add to that, with regards to where the spend is, so the way the data is set out, we are able to break that down by region, population size, and a number of different factors to try and see if we can find some correlations. And we've done that work, which is where we got to the 90% is being borne by populations of under 5,000. But what's actually really interesting to layer on top of this, in addition to what Nick was talking to with the pay scales for local government, is actually that a number of these local governments are supporting GP services in areas that are already entitled to incentive payments under Medicare, so the WIP and what have you. So even with that recognition of additional service provision costs and that being supplied through Medicare, there is still not enough to make it commercially viable to run through the Medicare system without external support.
So does that say that the incentive under Medicare is not adequate, or that provision of health services within those remote and regional locales basically doesn't fit the Medicare system?
That's exactly right from our evidence and our review, and that's why we are spearheading some work with stakeholders from the health sector, including Rural Health West, who you heard from earlier, with regards to what is an alternative service delivery model that would enable that equity and sustainability of primary healthcare provision in these areas where we've located that Medicare in of itself is not supporting the provision.
Is there any data that shows that a certain level of throughput's required through a practice to make it stack up?
Do you mean in terms of the population required to make the model sustainable and commercial?
Well, I suppose population would have some relativity to workload within the practice, although if you look at health data, they're likely to have per capita a higher load given the health statistics of people who live further away from a metropolitan area. I mean, there's a whole heap of factors that you can build into this.
Yep, and I think that's where the sort of the theory or the support we've had through the collaborative work we're doing is around recognising what those differentiations are with regional and remote primary healthcare provision. So you're exactly right. So while there might be, I'm not aware of one, but I'm sure one could create a number that says this is the baseline number of clients to make a solo practice commercially viable through Medicare bulk billing. However, you're absolutely right. The kind of the comorbidities or the complex health needs that varies across these different communities means that actually those indicators in and of themselves might not be the best way to measure what the ratio would need to be of service provision to population. And I think that's what it talks to as well, is that a one-size-fits-all model in such a complex health space across a complex regional and remote area is just really unsustainable and unpractical. And actually what's required is a willingness to investigate and embrace models that can flex to local need and local requirements.
So if we go to those communities that you talked about, in the southwest, if you go to those communities that you talked about in the southwest, that is there any your calculations are really based on percentage of rate base rather than physical numbers for it. You find that's the best way of defining what the impost is?
I think it's one way of doing it, and that's certainly where the 6 local governments within that alliance are fairly small in terms of population and their revenue basis. So for them, it's a really effective way of showing the impact it has on their wider service provision and responsibilities to community. I think there are many ways you can represent, the impact it has on local government and the outcomes, and that's just one of them.
So is there any...
I think just to pick up on Hannah's comments, it's about proportionality. So for us, in terms of relativities, the best way to demonstrate what effectively what the cost on the community is. I mean, rates revenue is really the only discretionary lever that local governments have in terms of generating revenue to deliver services and maintain infrastructure, particularly in regional Western Australia. So, whilst an amount of a few $100,000 might not sound a lot for a large metropolitan local government that has a budget of $100 million plus, for a relatively small regional local government that's got a very small ratepayer base, in terms of relativities, that few $100,000 is a significant impact on their budget. So I think Hannah's point is well made. It's just around us trying to find the best way to really articulate the message in a way that it's sort of best understood.
Yeah, okay. Is there any examples given in relation to the other services that are having to be dropped off, if you like, or not provided due to the need to subsidise primary health care?
Look, that would be some insights that we would be able to get from the sector if need be, but we really just focused on getting an understanding of what was being spent as distinct from, where the compromises were being made from a local government budgeting perspective. So we don't have specific examples we can share, but they're insights that we could pull together if required.
Well, it would support your argument in my view. If a community is providing 16% of their total rate base into health services that should be provided by another level of government, what are the ratepayers missing out on would be my question. And is council having to go to, or are councils having to go to other mechanisms to try and fund those services? So,
we're talking about fundamentally financially constrained local governments, largely here in regional Western Australia. So, to give you a bit of context for local government in WA, I mentioned there's 139 local governments. Collectively, they're responsible for maintaining 87% of the state's road network, which is sort of 120,000 plus kilometres worth of roads. And there's about $50 billion worth of assets collectively that they're responsible for maintaining. So there's a significant responsibility already for regional local governments when you think about management of that task. And there's a gap, we know, in the funding that's available relative to the need just for maintaining that road network as an example. So you've only got to visit some of these regional communities to see where, and not having to spend 16% of your rate base on GP services could be otherwise used effectively. But I think your point is well made. It assists in strengthening the argument if there is some basis behind where those compromises are being made, but I guess you don't have to look too closely to sort of see where that's given effect in regional Western Australia.
Does it impact on the potential viability of some of these councils? So if they've got $50 billion in assets, 87% of the road network, they would be, I assume, required to fund the depreciation on those assets. And if they're putting money into things that aren't their responsibility, surely that must have some potential impact on bottom line?
Yeah, well, they have to budget very responsibly, because that's the reality. And look, I think what's important to recognise here is these local governments that we're talking about are prioritising the provision of these services as a last resort. So their community are saying to them, and keep in mind that the community sit around the table as elected members in the local governments, they're saying a priority for us in this community is having access to a general practitioner. So they, from a budgeting perspective, they're having to prioritise that against something else that they would ordinarily like to do. It might be, an additional resource within the local government itself, that they're potentially not that they're not funding, or it might be, some reductions in their sort of capital expenditure program over a number of years. So they're providing these services because the community is saying that's a priority for them. But
look, I understand that perfectly. I'm trying to give you an opportunity here, I suppose, if anything. I'm sympathetic to your cause. Let's put it that way. And so trying to draw out as much as I can in terms of where the impacts might be. Access to a health service is absolutely vital, obviously, whereas you might just have to put up with a few more potholes in the road, which also has another impact as well. So I suppose they're the two sides of the coin that I'm just trying to think about as part of building an argument, I suppose.
Okay, thank you, Senator Colbeck. We've had connection issues a little bit with Senator Jordan Steele-John. Are you there, Senator Steele-John? And do you have questions?
Hello there. Can you hear me clearly?
We hear you loud and clear. Yeah.
Awesome. Okay, thanks. So to Walga, and I do apologise if this is repeating what you've already answered or shared with the committee. There's been some connectivity issues on my end. But we heard from earlier witnesses today about the scale of local government involvement in general practice, particularly in rural and regional communities in the wheat belt of Western Australia. And I was wondering if you've got any more specific information about precisely how many WA local governments are currently subsidising the wage or salary of a GP, either in part or in full, as opposed to other.
Yep, I can answer that, Senator. So based on the survey we did of our members for the financial year 2024-25, which is what my colleague from Rural Health West was mentioning earlier. So based on that survey of 108 mainland non-metropolitan local governments, 41 are currently providing some kind of support for GP services. So and we use that support term quite broadly because some of them will be providing vehicles, fuel, accommodation and the like, and some are providing salary guarantee or financial incentives. So 41 providing support, and then if we look into that a bit more closely, there are 22 local government respondents who are providing incentive payments or income guarantees, and an additional 6 that are directly employing their GP. Okay. The big caveat around that is that is of our respondents. So we had a 69% response rate. So I would imagine that all of those figures would actually be higher if we knew if we had complete response.
Okay. Thank you so much for that. And are you able to name the 6 that are doing that?
Unfortunately not. That's so our data was collected under the understanding of data confidentiality, and also with those ones with particular direct employment, there's that commercial in confidence requirement as well.
Of course. Okay, fantastic. Thank you. And in terms of the population size of those local governments, do you have Are you able to tell us anything about? Because it's not a role that local government would ideally be playing, and is obviously a result of gaps in the system. And I'm just trying to bring it to life a little bit more, so that we can talk about it at length in our report. Are you able to give us even an estimate of the number of the actual number of residents that are provided access to GP services in those 6 areas, or any level of granularity there?
Yes, we could certainly look into providing some aggregate data around the populations of the local government authorities that are providing support. I'd happily do that out of session if that would be helpful for the inquiry.
Yeah. If you could do on notice, that'd be great. And then if I could ask, in terms of other healthcare services beyond general practice, did your survey capture those?
So the first iteration of the survey we did in partnership with Rural Health West for financial year 2021-22 took a very broad scope survey approach to primary healthcare. So we collected data on everything from Aboriginal health, aged care, allied health services. They're the main ones I can think of from the top of my head.
Yeah.
The data we received back from that was so clearly focused in, so support was very strongly focused in on the GP provision, that when we did the survey for 24-25, we just focused in on GP provision support.
Okay. And in terms of the amount of ratepayer money that's being spent on GP subsidies or supports in one form or another, what's the total figure that we have for those 41 councils?
So the total for that 41 is 9.5 million.
Right. And for the 6 that do direct salary?
I don't have that data in front of me right now.
Okay.
You can take that on notice.
If you could take it on notice, that would be fantastic. And is it the first time you've asked this question in your survey?
Which question specifically?
Oh, sorry. I should probably tell you what I'm trying to get at. I'm trying to understand if the trend here. Are we seeing greater local government involvement in this space, less, or is it staying the same? Have you collected enough data to be able to tell us how this is evolving as a phenomenon over time?
So we can do a comparison with the survey that we undertook in 21-22 with the one we undertook in 24-25. What's interesting from the data is the total amount of support has increased by almost from 7.8 million to 9.5 million. What's really interesting is actually the number of responses was less. So there's a higher value of support being provided by less local governments. Now, our assumption is that is not because less local governments are providing support, it's just that they didn't respond to the survey. So we would say, we would suggest that 9.5 million is actually fairly conservative in terms of the real cost that's being borne by local government sector in WA.
Okay. All right. Thank you very much for that. It's very appreciated. And that'll do me, Chair. Back to you.
Thank you, Senator. May I ask in this survey, do you ask, is all this money going to GP specifically, or is there potentially money going to other allied health professional services?
So the data for 24-25 is purely GP practice. The data from 21-22 is actually identifies what's being provided for allied health as well. And in the report, which I'm happy to send to the inquiry or through the clerk, we provide a breakdown of what that spend is by region, but also by primary healthcare type as well.
Okay. Is there any reason that doesn't go for the 24-25 data? Did we stop asking that question, or is it all just emerged into GPs now?
The reason we didn't ask those questions again in the 24-25 survey was that the data from the original survey was a really, really strong focus on support being provided to GP services. So we just focused in on that for the 24-25 survey.
Okay. That, I know you said the numbers went 16% and they're not looking at that. You specifically said per capita is not a healthy way of looking at it. But was there anywhere where that $1,000 per head might be true?
I could have a look at the data, but I wouldn't know that. That would involve me doing a little bit of analysis on the data, but I'm happy to take that on notice.
If you take it on notice, I understand if it's too difficult and you can't get to it, but it just seemed a very high number, but it would be an amazingly big number if we're paying on that, or if a local government is paying that on top of everything else. So in your report, you're saying that no one model fits everywhere in the way to help these local regional things. That is messy for government because simplicity breeds a certain it breeds a certain productivity value when you're not going out and every local government area has a different thing. Is there any other method you're thinking of which may be able to fast track it? Because what we don't want is to spend significantly more money on verifications. I heard from previous witnesses today, when they're going through and verifying and checking things, it takes a long way, a lot of access away from what they should be doing, especially when it comes to applying for bespoke funding rounds or grants and the admin required for that. What is the suggestion on how we fix it that you have?
So it's a really good point, and we are operating with some political awareness in terms of putting up solutions that are viable and sustainable for federal and state government. I think when we talk about, I think the comment we made in our submission was that, a one-size-fits-all model wouldn't necessarily be appropriate because that would be in some ways replicating what we have in Medicare at the moment. I think if I was to sort of put a bit more detail into that, there are certainly some models or a model that is coming to the forefront of our collaborative work, which is around that multidisciplinary or mixed model that's mentioned in the inquiry terms of reference. That's certainly coming to the fore as what would be the most appropriate to respond to local need. I think the variation can be within the model. So adapting the model and having a model that has that inbuilt flexibility and agility to respond to local need is, I think, where our work is heading. We're still very much in the early stages, but I would suggest that that is the model that's coming out as a clear response. But it's the innate flexibility within it, which is where the value add may be.
It would be extremely difficult, and I don't know it has been done, but has there been any studies, research, a case study in the economic or opportunity cost of communities not having a doctor into what the lack of economic growth, or lack of diversity, you don't get a butcher, you don't get something else, you don't get other services because you haven't got a doctor. Are you aware of anything like that being done at an LGA level or anywhere in Western Australia?
Not within Western Australia. Certainly there's some anecdotal arguments around that. I would suggest maybe that the National Rural Health Alliance, I understand that they're doing some work around the economic impact of health provision in local economies. So they might be worthwhile having a conversation with.
Okay. And of the without wanting to know, again, what breached data, of the original people who filled out the data back in 21-22, are you aware of anyone that's been able to cease subsidies or other benefits to keep their medical professionals in place for 24-25?
I would say possibly quite the opposite. So we're not aware at WALGA of any local government that has managed to remove themselves from providing support once they have begun. And actually, if we look at the data sets in comparison, there are new local governments providing support that weren't in 21-22.
Right, we heard the difficulty from a previous witness of recruiting in regional areas today, that there's been a vacancy for, I think, 6 months, and there's been one application that was not up to standard required. Are you getting anecdotal evidence from these LGAs too? The trouble of replacing someone once they go is extremely difficult. Are they having to up the benefits or anything like that?
Yes, we absolutely concur with that. So typically the trends we are seeing in WA in terms of GP provision is a number of current local governments have been in community for a long period of time, and they're part of that community. They're embedded into life there. They are looking to retire, and the transition out is where it becomes quite tricky in terms of recruiting into that. I know that some of your conversations or questions to Rural Health West were around the kind of additional placemaking elements that enable recruitment for GPs and health services around housing. I'm sure Nick will want to talk to this as well, but for our sector, the accessibility or availability of supportive infrastructure and services to make somewhere a viable place to move your family to, whether that be housing, childcare, education, are really critical issues for local governments when they're trying to recruit talent to their regions.
It's one of the big challenges local governments are facing across regional Western Australia is attraction and retention of their workforce, be it skilled or unskilled, depending on what the nature of the roles is, and that's where the provision of general practitioner services is so critical in being able to attract families. One of the challenges, as you just described, though, is when one of these communities loses a GP. Inevitably, what we're seeing now is local governments having to effectively further layer the incentives, if you like, to be able to attract GPs to their communities. So it might be the provision of the clinic, it might be a house, it might be a vehicle. We've talked about underwriting of income for general practitioners as well. So effectively, it's putting communities in competition with each other to be able to offer the best packages to be able to attract general practitioners.
Okay. With that, is there anything else that we haven't covered that you'd like to say in closing?
No, just that we really appreciate the opportunity, and we would have loved the opportunity to have been able to attend, obviously, the committee hearing in person. So we hope there's still been value for you in us being able to do this over the phone.
No, it is. Thank you very much for your evidence. So thanks today. You've taken some questions on notice that you'll go and have a look at things. If we could have any response to the Secretariat by Friday, the 22nd of May, that would be fantastic.
Thanks very much, Chair, to you and the committee.
Thank you. Thank you. And I believe we've got Mr Moffat on now too. Okay. I now welcome via teleconference Mr Jeff Moffat from the WA Country Health Service, who is appearing on behalf of the Western Australian Government. I remind you, for the best quality call, please use landline or headphones to avoid using speakerphones. And I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. Is that correct?
Yes, it is. Thank you.
I think we've still got the previous witness on.
Right.
Just ask if he can mute or
sorry, we may have a bit of a... Mr Sloan or Ms Godsave, if you can mute, we're getting a bit of feedback. If you're on.
I think it's Mr. Moffat.
Oh, maybe we're getting him off it there. Okay. We're just having a bit of feedback, Mr Moffat. How are we talking to you? Via what?
I've got you set up on speakerphone, but
no, the speakerphone's not working for us. Is it possible to pick up or?
Try that. How does that?
Oh, that is spectacularly better. Thank you very much.
I can hardly hear you. Okay, hang on. I'll turn that up.
Is that working now?
Yes, I can hear you now. Thank
Great. Okay, for the Hansard record, would you please state your full name and capacity in which you appear today?
Jeffrey Moffat, Chief Executive for WA Country Health Service.
Thank you, Mr Moffat. Would you like to make an opening statement?
Sure, I've just got a few words here. I'm happy to start with that. Yep.
Right.
Yeah, Thank you. So on behalf of the West Australian Government, thank you for the invitation to present, and I do presume the committee have received the WA submission. The inquiry does provide an opportunity to address the disparity in health outcomes for people living in rural and remote areas associated with primary care, GP and specialist rural undersupply and maldistribution. It's obviously not a new challenge and is ongoing due to the complexity of WA to some extent and limitations in the design and operation of programs such as Medicare. This is evidenced by a number of factors, including, for example, a mid-term report of the National Health Reform Agreement, thin markets and Medicare constraints, and in features present within the new National Health Reform Agreement. It's also evidenced by over-reliance on international medical graduates in Western Australia, the highest of any jurisdiction in Australia. Evidenced by decreased access to Medicare per capita in rural and remote Western Australia, an increasing level of supplementation, which the committee may have heard about from local government and industry that has been evidenced for quite some time, but is increasing. And for us in WA Country Health Service, significant and increasing impact on hospital emergency departments. For example, with some 700,000 or so additional presentations over the past 4 years, proportionate to metropolitan settings, and also disproportionate impact on chronic disease preventable admissions in our inpatient settings. And finally, and probably most importantly, the disproportionate burden of disease in rural and remote Australia, especially for Indigenous Australians, set against the chronic inequitable access to care. So WA is at a significant advantage, as the committee would know already, in relation to accessing Medicare and PBS scheme. WA experiences more severe GP shortages than any other state. In 2025, WA had the lowest number of GPs per capita of all states, really around 96.8 GPs per 100,000 people compared to the national average of 112.1. And this maldistribution obviously impacts all of our remote and regional areas, but particularly so in areas where the committee is established today, Pilbara, Goldfields, Kimberley and the Wheat Belt. Geodemography presents unique challenges for health service delivery, both in terms of access and cost, and there are significantly higher practice overheads and staffing costs for private general practices and general practices that are non-private right across country Western Australia. For our organisation, WA Country Health Service, that does mean we see a disproportionate number of primary care presentations in many of our settings. For the committee's information, the total emergency department presentations for the state, WA Country Health accounted for 46% of those, despite only servicing 19% of the WA population, so a disproportionate burden there. So we would argue that WA needs more specific solutions that are more place-based and stress test for the WA context, where there's greater health need and complex service delivery challenges. We have seen Commonwealth-led reforms to Medicare over a long period of time, obviously. They have benefited large and regional centres to some extent, but more so the metropolitan area, with lesser impact across rural and particularly remote areas of WA. But we are keen to work together with the Australian Government in the co-design of locally driven solutions to address these shortfalls and deliver more appropriate and equitable health care to all Western Australians, irrespective of their postcode. Thank you.
Thank you very much. In your submission then, we've obviously spent a bit on the local government contribution to healthcare, and it's mentioned in your submission as well, but you've mentioned about industry contribution. I haven't heard that come up before. Have you got metrics around that?
We could deliver some. I won't have specific, it's obviously confidential information for industry, but we do have support for general practice, particularly across the Pilbara. So that's in been Port Hedland, Tom Price, Paraburdoo, Newman, Karratha, and Onslow for quite some time, and there are elements of incentives from industry in other parts of the state as well. So and that's more in the form of housing support, and so I guess support for general practices and corporate practices wanting to establish themselves in those towns as well.
Right. So that's on top. You mentioned about the geodemography of, Western Australia, very similar to Northern Territory in and really northern Queensland is a different thing altogether than the rest of Australia, and therefore the per capita Medicare, you think you're underfunded. This place-based stuff is required. You know, we were talking about local government before. I'm not sure if you heard what they were talking about, but the mixed message of funding it. How would you go if you had your fix, if you had your magic wand of federal support? What would it look like?
I think it's really important to include, obviously, there's a number of stakeholders in the conversation, as you say. Working with the ACCHO, the community-controlled health organisation sector, working with general practice, and obviously then with state government, I think there's ultimately got to be a design approach. It would be easy, I could grab some solutions. In some locations, we are the only, primary care provider available, but WA Country Health has been clear to not get in the way of the market. So where general practice wants to come in or a community-controlled organisation wants to establish itself, we make room and work in partnership with them. So I guess more enduring, so that's one issue, I suppose, making sure that the market is designed by those working in it, and it's pretty transparent. I would say I think more sustained and reliable incentives for practices that work for practices. So the complexity of Medicare and its application, I think, is very challenging for practices, especially when those incentives come and go. A good example, perhaps, to lean on would be in the state ABF, the activity-based funding system for hospitals and for outpatients. We get incentives provided both at national and state level that reflects our costs of service delivery. So in some parts of the state, for example, around Karratha, we'll be getting between a 40 to 60% premium to reflect the cost of delivery for an appendectomy or to deliver a baby or to provide an inpatient or emergency department occasion of service. It's evidence-driven, runs through a national pricing mechanism. Through IHACPA, the Hospital and Aged Care Pricing Authority. And I don't see that really reflected in Medicare, the extent of the cost of service delivery in the bush in terms of pricing mechanisms. So I do think there's some established mechanisms where aged care, for example, has recently been tipped into the Independent Hospital Pricing Authority's jurisdiction. I haven't seen Medicare to the same extent attempt to understand and reflect and compensate for the costs of service delivery for primary care, particularly in remote Western Australia, in very small settings where you've got low volume challenges as well.
Yeah. So you were talking about metro and large regional, some changes in Medicare. You talk about healthcare being a market, and I get that. What we're seeing is a market failure really in reality in regional and remote, aren't we? It's a market failure where normal market-based systems don't account for these areas. Of course, by number, it's so small, but by area, it's so massive.
Yes, it is. I mean, we see, so in WA Country Health, which is the organisation I'm chief executive for, we see market failure in, I guess, most market-driven mechanisms as the smaller and the more remote the community. Some communities don't need to be too far from Perth, though. Within 100 kilometres, there are small towns that experience market failure as well. Some of that proximity to the metropolitan area makes it very hard for them to attract and retain workforce reliably. But yeah, market failure in NDIS and aged care and primary care and the PBS system affect our organisation continuously. So we have to step in to those spaces, sometimes with Commonwealth agreed mechanisms like 19.2 exemptions, Section 19.2 exemptions, which I presume are known to the committee, which compensates for primary care provision by the state in an agreed way, which is required to be reinvested into that local area. But yeah, the market failure is significant in regional West Australia for our small towns and for our remote places in particular.
You just touched on something that we haven't spent a lot of time on today, but was mentioned earlier today, and I think the first witnesses, NDIS, with 160,000 people muted to go off that over the next 3 years. Does that look like extra strain on your, well, to me it looks like extra strain. Does that look like extra strain on your services, both regionally and metro?
Look, I think it's hard to know the design of the reduction in participation, so hard for me to comment at this stage. I guess what we do know is the Thriving Kids program is proposed to return to the state, so that will involve, in rural and remote areas, that will involve providers such as WA Country Health Service and the community-controlled organisations, for example, I suspect needing to step into that space and pick up some of the demand. I imagine with that many participants coming off the scheme nationally, it's hard to see there will be no impact, but I guess until we know the design of that, it's hard to really understand how it might affect rural West Australians.
Right. You talk about the lowest GP to population ratio nationally in the country here. There's been lots of stuff about rural medical schools trying to train closer to people and these sorts of things going forward. Is there a lack of supply? Obviously, it's harder without multiple large regional centres to do it in Western Australia. That could be a contributing factor. What do we see there about being able to get a greater supply to the regions in Western Australia and attract those people away from incentives, getting people from regions to training? From an outsider, I'm from the other side of the state. I don't know what the local challenges are to recruiting and training regionally here.
Well, I think there's very well established evidence over several decades now that if you want a good, reliable country workforce, particularly medically, the more you can select from the bush and train in the bush, the better your outcomes. It's really quite powerful evidence now. So the rural generalist pathway, which we participate in, I think the decentralisation and the more flexibility being adapted by universities around regional training centres, they're all very good developments, but they're fairly recent. They will take at least a decade, I think, to start to have a material impact from point of inception. So we're a few years into the regional training centres, but the rural generalist pathway will probably have 4 to 5 years to run for us before it starts materially changing distribution. So those are really welcome incentives, and far more inclusion and availability of training, not just for GPs, but for nursing staff, allied health staff, Aboriginal health practitioners, is a surefire way that's evidence-based to deliver and retain people in rural and remote settings because they come from those settings.
This has been said anecdotally. I haven't seen a submission that states it specifically, but in conversations privately around some of this, a lot of people are talking about the desire of so many people who practice medicine now to specialise far more quickly than they have in the past, leading to a shortage of GPs. Are you seeing that across the wider? You have a wider view of medicine than just the GP and stuff like that. Are you seeing that as a reality, or is that just an opinion that's not supported?
Look, I think it's very well established that pathways to becoming a specialist have become traditionally much easier than pathways to becoming a GP. The state obviously supports most of the specialist training, and for someone, for a young doctor or a doctor commencing their vocational training, they step onto a conveyor at the beginning of their training program and step off typically at the end of 5 years when it's all managed for them. General practice has not, up until the rural generalist pathway, general practice has not had that ease. Trainees have had to move amongst providers and design their own programs in order to become a GP. So it's been much, much harder until recently, where general practice, I think, is starting to be regarded truly as a specialty. And we're making training pathways much more coordinated. So, for example, particularly in the common stories for parents wanting to have children, along that journey, that they're not having to worry about their entitlements and separation of their service and a lack of employability. When you have continuous training pathways, balancing your family responsibilities and your financial responsibilities and family responsibilities is much easier if you have a commitment for the training program from start to finish. And general practice hasn't had that until fairly recently. So I think So I think specialisation has had that benefit for trainees looking at their choices. Specialisation is also part of a trend in medicine, but we are starting to see generalism return. The rural generalist pathway is part of that, and a true place for generalists in our system, even in the metropolitan areas. So whilst we've ended up with a highly specialised medical workforce, my observation would be there's some balance coming back, and most colleges are now expecting their specialist trainees to have a level of generalism and particularly exposure to rural and remote practice as part of their training.
Okay, thank you. Might give you to Senator Colbeck now.
Thank you, Mr. Moffat. Thanks for your evidence. I suppose this is stating the bleeding obvious, but in terms of delivery of service for what you're looking to do in this state, remoteness is a feature of what you actually do.
Yes.
Yeah. So I'm going to bleed into another inquiry that's having hearings tomorrow here a little bit too, because that might help both inquiries. Firstly, I want to go though to the impact of the 1 November reforms, which you make some reference to in your submission, but telehealth would be a feature of a lot of the service provision you would have done, I would have thought, and the restrictions around that and requirement to visit a GP, you're starting to add a lot of pressure points of your reality together. Can you talk to us how you're looking to manage that and what the impact is?
Are you referring specifically, Senator Colbeck, to the changes on the 1st of November, or more broadly?
Particularly the requirements to visit a GP on a regular basis to maintain access to the telehealth services. I mean, this is a place of school of the air and all of those sorts of things. You know, technology for delivery of some things has been around for a while, but would be a critical element of health delivery services, I would have thought. And we've had evidence from other communities that don't demonstrate anywhere near the remoteness that you're talking about the impact of those 1st of November reforms on the capacity to deliver service, given the requirement to sit face-to-face with someone, and how that might be modified to make it easier.
Yeah, I think during COVID, I suppose you saw some very practical and pragmatic changes to access to virtual medicine. That's I think served the country well at that point in time. There is obviously a balance when you want to have resident general practices and GPs and other health professionals in the bush. One of the risks of making virtual care available is that their core market gets undermined by corporate providers operating out of metropolitan areas. So there's some nuancing around virtual care that is important, and we respect that.
And
however,
we heard some evidence to that effect too in Albury, I think, recently. So,
right,
point well made.
Yeah. However, though, it's given the virtual care is really intended, telehealth and virtual care is intended to provide access to those people that have difficulty getting access to a regular GP, whether that's because their GP turnover is really high, or there's a corporate practice operating in that area, or simply because of their geographic disadvantage. I think requiring someone to have regular contact, face-to-face contact with a GP in order to access something that's necessary because they don't have access to a GP does not make sense. And I can't claim to know how that's administered by Medicare, but I don't think it's very empathetic to the situation that communities and patients find themselves in the first instance, that requires them to adopt digital technology to actually get care. That's probably the simplest way I could put it. I don't know if that makes sense in terms of how I've expressed myself.
Yeah. Okay. Well, I think you've given us an opinion without necessarily a solution, and others have tried to provide solution without opinion. So I suppose we're covering both sides of the penny. But
yes, I'm more than happy to talk to solutions. Maybe if I talk a little bit about what WA Country Health Service does itself. Now, this is outside of the primary care system, but we provide a 24-hour-a-day command centre, a virtual care service that services over 100 sites across WA, 24 hours a day. That's mental health, obstetrics, emergency care, palliative care. So we could not possibly provide the access to specialist capability and general practice type capability for patients needing to attend GPs for primary care reasons without having that sort of service available. So we're well experienced in the need for virtual care. However, it does need to be well governed. You don't want perverse incentives going to place. But I would have thought, again, working with reliable general practices with track records, and particularly the community-controlled sector, who have a long-standing commitment about trials of what might work, would make a great deal of sense. So I think for patients and families who have trouble getting access to a regular GP, there really does need to be a more flexible way of providing access to trusted general practice and committed general practice without requiring such preconditions. So I guess I would say a design with the sector and a trial about that design with the sector is the smartest way to go. I'm not a primary care general practice expert, and I wouldn't profess to be. It's a very complex set of conditions for general practice, but my suggestion would be to trial some work in partnership with known and well-established general practices that are committed to being in those communities to make it work would be the go.
Okay. Would that include, say, for example, and I'm very mindful of the comment that you've made a couple of times with respect to corporate health services operating out of the metro areas and effectively transmitting back out, perhaps some proximity requirement. I mean, how do you deal with those the corporate type organisations that come into those markets? I think your point about them effectively undermining them as well, to a certain extent, is one well made, and a lot of the evidence that we've had has come from those more localised providers, but still seeking to provide care from a regional area into a regional area.
Yeah, I mean, obviously the Medicare themselves would have the sort of data and I guess the sort of sense of general practice's capability to continue to service people locally. So I guess it requires some good data analytics about the capacity of general practice locally, and including wait times, and therefore the need for supplementary virtual care. So I think there's a fair bit of data analysis to do. But I imagine a track record of having a presence in the community and working to community should be part of that. I would have thought if you're going to have the benefit of accessing virtual care made available to you, you should have a track record of demonstrating a commitment to regional settings, including being physically present in those settings. Again, it will be place-based, because in different parts of the state in Western Australia will need different solutions, but with, I guess, consistent principles being applied. My main concern at the moment is, unfortunately, for patients who can't access services, they're the ones that have to demonstrate they've got a regular connection to a GP who's either not available or overworked.
Okay. We've explored somewhat the capacity or the utilisation of scope of practice reforms that are being undertaken quite a bit at the moment. in terms of maximising the capacity of the people available within the system to provide service at the moment. Do you have any thoughts or information in relation to that? We've had conversations, pharmacists, nurse practitioners, other professionals about expanding their scope of practice to actually squeeze more out of the existing people within the system without or by reducing their limitations.
Sure. Look, I think some of the reforms that have occurred, nurse practitioner reforms, both at state and national level, have been good developments. The Medicare incentives, generally speaking, for whether it's allied health or nurse practitioners, either often happen under delegation and referral, or attract a significantly lower comparable item number, if you like, in terms of Medicare rebate. So I think if we're wanting to sort of stimulate a reliable market, both in terms of allied health or nurse practitioners, the removal of, I guess, extensive need for delegation or referral of care, combined with appropriate remuneration, would be two obvious things to do, I would have thought, because that has constrained the growth of those sectors over time. But they would, it's very specific to the item number and the professional we're talking about. I'm making a broad statement, but I do think we can see that GPs are overworked and under-accessible in Western Australia, and you can see that nationally in rural and remote Australia. So making better use of the professionals that are there and available in a way that's sustainable for their practices makes a great deal of sense to me.
So reforms to Medicare support aligning with the reforms to scope of practice would be a necessary feature for this, the full element, for the full capacity of the scope of practice reforms to take their desired effect.
I think so. I think the market's demonstrated that in terms of the limitations in nurse practitioner growth and development, and the limitations of allied health private practice growth as well. Generally speaking, both of those sectors have required sort of broader organisational support, or have operated in more lower cost environments in order to be successful. So in the same way that we're talking about GPs needing to, I guess, be remunerated in a way that accommodates the costs of their practice and their service delivery, the same would apply to nurse practitioners and allied health professionals as well. So yes, I agree. I think Medicare reforms to complement scope of practice reforms makes sense. I would emphasise, I think it's sometimes the modified Monash model approach to the very blanket approach to what are very different settings is unhelpful. It creates perverse incentives at times, rather than a more place-based approach of looking at data in a more agile way. So not over long periods of time, but in a more agile way to ensure that incentives are available in places, for example, in Halls Creek, not far from where you are now. That there's a very significant undersupply of private practice. The fact that there's virtually none, apart from some visiting services. There is a community-controlled organisation. Whereas in Kununurra, you do have a level of market there in terms of allied health, general practice, albeit slim. So those sorts of areas, to me, need much more focus than they're currently getting, both in terms of allied health, nurse practitioners and general practice.
It's. I was actually going to ask you about the MMM model, but I won't open that can of worms too much, so because you've already been there. But what you're saying is that that isn't necessarily the appropriate way or set of parameters to look at some of these particular circumstances that arise in some of these communities, or in your experience.
Yeah, it's not discerning enough. I don't think that many examples of, and I appreciate it's difficult to have a national model that's ubiquitous and reliable, but I do think a more agile mechanisms for places that demonstrably struggle to attract and retain health professionals is needed. It's quite blunt, and as we've seen, general practice and other health professional supply in outer metropolitan areas dwindle. We've really seen, I guess, some drift from our sort of inner regional centres into those outer metropolitan settings as well. And I don't think that has been well adjusted for in the triple M model. So I think it needs to be more place based. I guess addressed in a more nuanced way, as is contemplated in the National Health Reform Agreement, a bit more place-based way than large swathes of Australia, and assuming that they're relatively similar through a set of metrics that aren't necessarily health sensitive.
Did you see much of a movement of GPs to more metropolitan locations off the back of the reforms that came in about 2 years ago in relation to requirements for location, for particular incentives?
I certainly have had anecdotal feedback in relation to, I don't have any data or evidence in front of me I can talk to you about, but certainly when areas of unmet need widen to outer metropolitan Perth, we do know of GPs that, for family reasons, chose to relocate, and that's understandable. It's a market mechanism, but there's no doubt that the inclusion of some outer metropolitan areas in those areas of need has resulted in some or in fact, rural and remote GPs moving. There's no doubt about that. Now, what was the net market effect? I couldn't tell you, and I guess it's just an amplification of what typically happens once, particularly international medical graduate doctors and health professionals have served their time in the bush and can access Medicare in metropolitan settings. That happens anyway. It did seem to accelerate that at the time, but I don't have data for you. I'm sorry.
Yeah, okay. Well, if there's anything that you have, I'd be interested in seeing that. I just want to go to back to the conversation you were having with Senator Cadell in relation to the local government stuff, and I don't necessarily have any more specific questions on that, although the reliance on air services in a lot of your communities for provision of health services or to transport people to locations where they can actually access health services. And I just wanted to overlay that with the information that we got around the amount of money some small local government areas were having to put in to support delivery of health services in their local communities. As I suppose, I mean, the access to aviation is an absolutely critical element of delivery of health services in a lot of the communities here in Western Australia, is it not?
There's probably two forms. We provide and we contract acute medical retrieval services primarily through RFDS. Yep. That's an acute retrieval service for those that are seriously unwell, moving from hospital to hospital typically, and the Commonwealth does fund some primary care retrievals as well, obviously, with RFDS to go from non-hospital settings into hospital settings in regional settings such as there in the Kimberley. The other way in which we do use airline access is for patients requiring specialist care. This is our patient PAT system, patient assistant travel scheme. in order to access specialist care, if it's more than 16 hours in duration of travel, air travel is required. So Pilbara, Kimberley, some parts of Goldfields, and some parts of Murchison and Gascoyne do require regular access to airfares to access specialist services, either in Perth or in a larger regional setting, but typically Perth.
So what's the scope of the specialist services that would be required?
It's any registered specialist. So it doesn't include general practitioners. It's for any registered specialist. Our scheme is currently being a medical specialist, that is. Our scheme is currently being amended policy-wise to include some limited dental and specialist allied health access as well. State government announced that at the last election, and that's just flowing through as a policy change over the next few months.
So is there any support given to communities with respect to the provision of their aviation infrastructure in that sense that you're aware of?
Do you mean airstrips and terminals and those sorts of things?
Yeah, and well, or is it all passenger related? So it's by the sound of it, it's passenger related. You've got the PAT scheme, which I get, similar scheme in Tassie for specialist services in Victoria or off Flinders and King Island, for example. But it's all passenger related direction rather than...
Yes, yeah, we don't have arrangements directly with airlines or local governments or airports. It's all individual reimbursement back to patients and families. Yeah.
Okay. I'm really interested in this financial impact on councils to provide health services. And for example, if I went to King or Flinders Island, where a big chunk of their budget is also providing aviation capacity, so terminals, runways, all of that, and that sort of thing. Just the cumulative impact on a lot of these regional services, regional communities for provision of service before you get to the basic elements of local government operations.
Yes, look, in terms of sort of state services, so specialist services provided by the state, we've worked really hard with telehealth and virtual care through our command centre and some other specialist services as well, such as cardiology, burns, to ensure that we try and provide virtual care either to a person's home or to their local health setting, usually the hospital. So we've worked really hard to reduce the need for travel for patients as much as we reasonably can. In terms of access to specialist services, specialist medical services, some of those are amenable to virtual care. Some need direct face-to-face attendance as well, especially surgical workup and those sorts of things. But I think the cost to local government, I think, are primarily around general practice. I'm not aware of local governments providing much subsidy into specialist care space, and the constraints around specialist care access in the bush are pretty significant with Medicare. So we see some of the Medicare billing per capita rates at 10% of national averages in places like Pilbara, for example. So I do think the Medicare settings for specialists in particular don't take account of the low volumes that they encounter in some of these settings, the travel that they have to undertake to get to sites, and the costs of service delivery and practice, particularly for resident specialists, of which there are very few in the remote parts of the state that are sort of surviving on the Medicare system alone. So the actual attendance per capita for specialists in remote Australia are extraordinarily low compared to averages.
Okay. Your submission talks about the workforce incentive program payments being very low comparatively. and making some changes to the way that works, and potentially using WA as a trial base for that, building that reform process. What do you think it might need to look like? That you're talking about 16,469 in 22-23 per thousand population. So what is the variance on that for the other jurisdictions, and what needs to change?
Look, to be honest, I'm not much of an expert in the practice incentives program area. We are relying, I guess, on either Commonwealth-driven or Commonwealth Engaged Specialist-driven reports. It's a KPMG report, that one I think that you're referring to. I think the main point we're making there is the scale of the practice incentives program just does not match the reality of the economic case for running a practice in some parts of Western Australia. So again, place-based solutions that take into account real-life issues such as the input costs of service delivery, things like workforce premiums and costs and workforce turnover, combined with I guess the realities of the low volumes for some of these practices as well, and the extensive travel times. I really think it's about trialling processes in partnership with general practice and using WAFA. They're a very experienced organisation to understand where place-based solutions that can be trialled might have better results. Our observation there is simply that the incentives don't seem to be enough to attract the workforce that we need.
Hence, so to take it full circle, hence the need for local governments to step up and throw up to 16% of their budget in some circumstances at receiving or having a GP in their community.
That's right. And often for communities with lower volumes as well. So, look, we empathise a lot with local government. We do our best as an organisation to provide incentives to GPs as well. We run a country health investment program for GPs in many parts, mainly in the south of the state actually. And we work with local government, and we're very conscious that local governments had to step into the space of supporting general practice more now than probably any time in their history.
Okay. Just one last question in respect of, you would have a workforce support agency here operating in the state the same way that other states do. Is that one that works across the whole state, or is it does it have responsibilities for particular areas?
So Rural Health West is the state workforce agency, mainly dealing with doctors, but also to some extent allied health professionals and nursing staff at times. They're statewide. We contract with them, but their primary contract is with the Commonwealth, obviously, to deliver all the usual workforce incentives and what would you say, settling in, transition programs for families, etc. So we work very closely with Rural Health West. They're a good agency, very focused on strengthening general practice and, in fact, health professional take up of vocational opportunities at the bush. So yes, we do have Rural Health West here.
Okay, thank you. Thanks, Chair.
Thank you very much, Mr Moffat, for your evidence today. If you've taken any questions on notice or are going to chase anything up, we ask that you provide your response to the Secretary by Friday the 22nd of May. Thank you again. So,
all right, thank you.
That concludes today's hearing. Thank you to all witnesses who appeared. Thank you to the Secretariat for coming here, Hansard and Broadcasting. Thank you for the town of Kununurra for having us. The committee stands adjourned.